Hi, Janelle. Can you hear me?
Yes, I can hear you.
Wonderful. We'll start soon.
Okay, sounds great.
Okay. Let me also share my screen with you and let me know if you can see it. Do you see my screen? You are mute.
No, I can't see it. I just see your big picture. Let me see if it's something on my side. Oh, now it shows up. Yeah.
Okay, just having that schedule for that.
Yeah, now I can see the schedule.
Wonderful. Nisha, how are you doing?
Hi, Dr. Gohar. I'm good. How are you?
Wonderful. I see Iman Mohammed joined. And Iman and Mohammed, if you can join with video, will be great.
Hello, Dr. Gohar. I wouldn't be able to join with video right now, but later in the course I'll be able to.
No problem. Well, how are you doing?
Hello, Dr. Gohar. How are you, sir?
Wonderful.
Thank you so much for thank you so much for this amazing course. I'm just on my way back home. I was in Doro, so they asked us to stay until we are done with the rounds, and I'm just just a few minutes. I'm gonna be back home. Sorry, sir.
Oh, just drive safely. So
thank you, sir. Thank you.
Wonderful. Pritham, how are you doing?
Good, Dr. Gohar. How are you?
Wonderful. Okay, we'll start in a couple of minutes. Just we'll give everybody time to participate, and then we will start. When everybody joined, did it tell you that the meeting is recording? Yes. Okay.
Yeah, I did.
Wonderful. Okay, looks like we started to have good number joined. Just wait for 1 minute for more people to join, then we will start. Okay, good afternoon, everybody. Thank you for joining the course. And this is the 9th course that we are giving here for critical care refreshing. So probably you had heard about all these lectures during the last year in different rotations, especially in the ICU rotation. But this course is mainly made for categorical interns to prepare you to become supervisor in July. With the COVID, we are not able to do the hands-on part that we usually do in the skills lab, but we will get you some course probably in July or August for ultrasound and echo that myself and Dr. Baweja direct. So Feel relaxed and enjoy your time during the course. There is no stress at all. Just we are here to discuss things together. We'll try to be as interactive as we can. And also for better interaction, I will have some poll everywhere so you can answer your questions, and that when we ask you for a question, so we don't know who answered what, so feel free to answer what you think is best answer for you. And I will tell you what is the result of the answers, and then we'll discuss the correct answer. Especially today, this is the agenda for the 3 days. Everybody sees my screen? Great. So for today, we have a little bit of change from the schedule I sent to you, but we will start with the pre-test in the next 10 minutes or so. And this pre-test will be 40 questions about certain informations I want you to learn about the ICU. This is like 45 minutes. You will learn about 40 things I want you to learn about critical care management. And we will have the question. You will send the answer to the poll everywhere, and I will show you how to log into that. Then I will give you another lecture about non-invasive positive pressure ventilation. This lecture was supposed to be at 4:15, but Dr. Mustafa, who is giving the electrolyte abnormalities, had to delay her lecture till 4 o'clock. Then Dr. Baweja will give you 2 lectures back-to-back about acute coronary syndrome and congestive heart failure. This is the schedule for today. Starting tomorrow and Thursday, we will start exactly at noon. So at noon exactly, we will start the lectures. Tomorrow we will talk about 2 sessions for ventilator management, lecture 1 and 2, and I will be talking about that. Then Dr. Waidi will talk to you about the endocrine emergencies for nearly some hour and 30 minutes. Then we will have short break. Then I will talk to you about pneumonia. We'll talk about community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia, the new guidelines. So community-acquired pneumonia guideline in 2019. Hospital-acquired and ventilator-acquired pneumonia is 2016 guidelines. Then we'll talk a little bit about COVID. I wasn't planning to talk about COVID because the guidelines change every few days, but I will talk a little bit about COVID because probably it's a hot topic. So I added that to the pneumonia lecture this year. On Thursday, Dr. Salzman will talk to you for 1 hour about acid base, and it's mainly the acid base from Dr. Salzman will be quiz-like. So he will give you cases and then discuss with you. So try to review the acid base before you meet with Dr. Salzman on Thursday. Then I'll talk to you a little bit about sedation in the intensive care. This was something that was, in addition to the non-invasive positive pressure ventilation, I was requested to add those by the previous groups. So this is what I want you also to do. Anything else you would like to add to the course for the next years, please send me email and recommend it to me. Then we will talk about the ACLS with Dr. Hellman, who is our ED doctor, and she is teaching or doing the ACLS classes in our skills lab. Also, I want you to review the ACLS because the ACLS will be very open discussion with you, so at least review the ACLS cards. Then I will give you the last lecture, which is shock management. We'll discuss a couple of cases about shock to have some idea how to manage shock in the intensive care. One item I think I would like to add, which is acute stroke, management of acute stroke, and this is something that I'm thinking about adding. I need just to find some time for that lecture, but this is one lecture I think needs to be added to this course, and I'm planning to add that sometime, maybe next year or so. Then the hands-on part, I hope the COVID will be better in the next few years. We can resume this part in the skills lab. The COVID gave us the chance for Zoom, so people can attend that, and this gave us some more time for didactic. So we are losing the hands-on part, but we are getting more didactic time. So we are compensating for that. Then we'll get you the ultrasound echo course in the beginning of your second year. So you will have a big part of the hands-on that we do during the course, or we did in the course before. So any questions about the schedule for now? Okay, so please stay on mute if you are not participating in discussion. Turn yourself or unmute yourself when you want to answer questions, then turn yourself on mute again. We have 10 programs that asked us to send them the recorded course. So we are sending that. So we would like to get the best quality of the sound as much as we can when we send that to the 10 programs. 9 programs are here in the US, and 1 program in Cairo University in Egypt, where I had my med school. So we'll send them the course, the recorded course at the end, so the residents can review. Great. So I will stop share here, and I will start to share with you the pre-test part. Please let me know if you see my screen. Yes. Okay. So first thing I want you, so you can participate, this is Pull Everywhere. So send a text to this number. So use your cell phone, send text to this number. The number is 37607. And this is my first name, my last name, 064. Letters should be in capital. You will get the response that you joined, and stay there. When you get the response, we will start the questions. Everybody joined? Wonderful. Let me move to the first question. I'll read the question, then I will leave the answers in front of you. So the first question, we'll have several questions about ventilator management. I want to be sure that you have the proper idea about very basic things regarding ventilator. So first question, tidal volume on mechanical ventilator is based on A, actual body weight and disease, B, ideal body weight and disease, C, only on disease, D, Asian disease, E, only ideal body weight. Please send your answers. I'm getting some responses. We'll give you a few more seconds to get the response. Okay. Up till now, I have 55% for B, 18% for A, and 27% for E. So we have some room for improvement. So the correct answer is ideal body weight and disease. So who picked A, actual body weight? We don't use, if I will ask you, if you gain 100 pounds next year, how larger will be your lung? Probably not. If you lose 100 pounds next year, how smaller will be your lung? Will be the same size. So actual body weight is not the correct answer. We had E, only ideal body weight. So ideal body weight is part of the answer, but also different diseases will have different vent settings, like COPD versus DKA versus ARDS versus restrictive lung disease. These are common diseases that we see, and we'll talk about that in the ventilator lecture at noon tomorrow. Second question, let me clear the answers so we have new responses. Okay, second question. For a man 5 feet 10 inches tall, ideal body weight is, and this is how to calculate the ideal body weight. So pick your answer and send me the responses. 73 kilos versus 68 versus 78 versus 83 versus 100. And this is how to calculate ideal body weight for a man. You can use your phone if you would like to calculate. Okay. Anybody else didn't send answers yet? Okay. He's a man, 5'10", 5'10", or 178 centimeters. Okay, I have A, B, C, and D answers everywhere. So I have 29% for A, 43% for B, 14% for C, 14% for D. So let's see how we calculate it. Okay, for ideal body weight, for man, it's 50 kilos for the 5 feet, and for every inch above the 5 feet, it is 2.3 kilos. So his man, 5'10", will be 50 kilos for the 5 feet, and 2.3 times 10 inches will be 23 plus 50, 73. So A is the correct answer. Make sense? So A is the correct answer. A man, 5'10". This is how you calculate the ideal. I'll clear the responses. Then we will go to the next question. Now we have a woman, and she is the same height, 5'10". What will be her ideal body weight? Start sending your answers. These are your options. I have 100% for one option. Did everybody send the same option, or only one person sent the option? Okay, so it looks like 100% answered B, 68 kilos. Again, to calculate for a woman, it is 45 kilos for the 5 feet. So 5 kilos less than men, because less body mass, less muscle, less bone density. So they have less weight for the 5 feet by 5 kilos. So 45 kilos for the 5 feet, same 2.3 kilos for every inch above the 5 feet. So she is 5'10" woman, so will be 5 feet, 45 kilos plus 23 would be 68 kilos. For here in Truman, I'm not sure about St. Luke's, other hospitals, we have the height in centimeters. To make it as a quick calculation, take 100 from the man height and 105 from the woman height. This will be a little bit higher than your ideal body weight. So if we say 5'10" person, he is 178 kilos, right? So if we take 100 from that, he is 178 centimeters. If we take 100 from that, will be 78, will be a little bit higher than his ideal body weight. For the woman, if you take 105 from her height, this remaining numbers will be a little bit higher than her ideal body weight. You can use this number, will not be very big difference, but you can calculate based on that. Everybody knows his height, right? So I'll give you a couple of seconds to calculate your ideal body weight. We don't want you to share it. Just calculate it and see what's your ideal body weight. So I'm 5'10". That's why I use the example for 5'10". So I have a man 5'10". I know he is 73 kilos ideal body weight. If he's 1 inch taller than me, then he will be 75. If he is 1 inch less than me, I will know he is like 71, or I can use 70 or so. So this is an easy way also to calculate. Know your height, and the same gender compared to you, 1 inch higher, 1 inch less. This is something that you can use to calculate the patient height too. I'll clear the responses and we'll go to the next question. The fourth question, definition of ARDS based on the modified Berlin definition in JAMA 2012 is, these are your options, A, B, C, and D, and E. Send your correct answer. So I have the acuteness, how many days, within how many days. Then I have bilateral pulmonary infiltrate in all the options. Then PF ratio less than 300 or versus less than 200 versus less than 150. Then should be on no PEEP versus PEEP of 5 or 10 or 8. So we have also answers all over the place except A. So we have B 25%, C 50%, 13% for D, 13% for E. So the definition for ARDS is acute within 7 days, bilateral pulmonary infiltrate, and the pulmonary infiltrate shouldn't be from heart etiology. Patient can have heart disease, but the cause of the infiltrate is not pulmonary edema. Then PF ratio less than 300 and PEEP of 5. For the PF ratio, if the patient is on 100% FiO2, your FiO2 is 1. So 100% is 1. So if your ABG shows 90 oxygen on 100% oxygen, then it's 90 over 1 will be 90. So the 100% is 1, 50% is 0.5 when you use the FiO2 in this PF ratio equation. They should be on PEEP of 5, so C is the correct answer. And this is the modified Berlin. We'll talk about that tomorrow, and I'll get you the reference. I would like you to read this article. Okay, let me clear the responses, and we'll go to the next question. Question number 5, tidal volume in patients with ARDS is. These are your options. So send me your answers. Mainly, what number per kg, and is it actual body weight or ideal body weight? Is it 6 versus 12 versus 12 versus 10? the repeat numbers is actual body weight versus ideal body weight. Everybody send his answer. This is another question. I have 100% for one answer, which is answer B, and this is the correct answer, 6 ml per kg ideal body weight. Anybody heard this lecture from me before? What did I tell you about ARDS, 6 ml per kg ideal body weight? If you don't remember, I usually... Go ahead, Well. You heard about it? Say it.
Yeah, you can forget your name, but you don't forget the tidal volume for ARDS.
Right, so this is very important information that you need to know. They love it in the board, a lot of board questions, even in the ITE exam and in the real board. 6 ml per kg ideal body weight, tidal volume, and I usually tell you, the only time you are allowed to forget 6 ml per kg ideal body weight for ARDS in your board exam if you forget your name. As long as you still remember your name in the board exam, please remember 6 ml per kg ideal body weight. It's the only thing by itself that improves mortality from 2000 till now. All the other things that improve mortality only if you use it with the 6 ml per kg ideal body weight. That's why they love it in the board. So if you remember your name in the board, remember 6 ml per kg ideal body weight. Okay, let's move to the next question. Goal plateau pressure in ARDS is, and here we have different numbers and we have either centimeter water or millimeter mercury. Send your answers. Pressures on ventilator and on non-invasive passive pressure ventilation are on. Okay, so looks like send more answers if you didn't send answers yet. So you need to know the number. Above this number is harmful, and you need to know what's is it centimeter water or millimeter mercury on ventilators and CPAP, BiPAP, EVAPs. Okay, we have three A, C, and D. We have A 67%, we have C 25%, and we have D 8%. So this is 30 is a number that you need to remember. Above 30 centimeter water is harmful. So all the pressures on ventilator, non-invasive pressure ventilation are in centimeter water. So less than 30 centimeter water. So in the ARSNet study, if with 6 ml per kg ideal body weight, the plateau pressure was higher than 30, they reduced it to 5 ml per kg ideal body weight. Still above 30 plateau pressure, they reduced it to 4 ml per kg ideal body weight. So less than 30 centimeter water is the correct answer. So A is the correct answer, and I have at least 2/3 have the answer. Let me clear responses, and we'll go to question number 7. In COPD or asthma, obstructive lung disease, the best ventilator settings are. So here is your answers. Do you need high tidal volume versus small tidal volume? Do you need long expiration versus short expiration? Do you need high flow versus low flow? By the way, as I will tell you tomorrow, our ventilators are auto flow, but if you have on the board the question that's asking about the flow, you need to pick the question that fits. So start sending your answers. Okay. Okay, looks like we good. Okay, so we have some area of improvement. I have 56% for option C, 11%, 10%. Things are changing a little bit. So 9% for B, 9% for D, and 18% for E, and 64% for C. So most answered C, which is a correct answer. So we need low tidal volume, so patient with obstructive lung disease can exhale it, and you need to have low rate. So low rate, if you have a respiratory rate of 12, you have 5 seconds for every breath. If you increase the rate from 12 to 20, you have 3 seconds for every breath. So increase the rate from 12 to 20, you reduce the respiratory cycles by 2 seconds, and all these 2 seconds will be from your expiratory time. So we need lower rate, we need high low I to E ratio, so means longer expiratory time because they need some time to exhale through the narrowed airway, and we need high flow. By high flow, this will lead to short inspiration and longer expiration in the cycle. The higher the flow, the shorter the respiratory time, and the longer the expiratory time. So C is the correct answer. Low tidal volume, 6 to 8 ml per kg. Low rate in the low teen, low inspiratory to expiratory ratio, which means longer expiratory time, then high flow will give you short inspiratory time, longer expiratory time. And we'll talk about that again in details tomorrow in the ventilator lecture. I'll clear the responses. Then I will go to the next question, number 8. In DKA patients with healthy lungs, if intubated, the best initial ventilator settings are. These are your options. Read the options and send me your responses. Okay, up till now I have 83, 86% answered A, and 14% answered D. Ratio is changing a little bit more towards A. So high tidal volume, what do you call the respiratory breathing? How do you describe it in patients with DKA with acidosis? What do you call the type of breathing?
Cosmal breathing.
Wonderful. So I was saying cosmal breathing. That's correct. How do you describe the cosmal breathing?
It's rapid and shallow.
Can you say that louder?
Rapid and shallow.
Okay. For some reason, well, I hear this answer all the time. So
It's rapid and deep.
It's rapid and deep. Correct. So rapid and shallow. I always hear it well. So it's not a strange for me to hear this answer. Never in any lecture that I give this lecture 12 times per year for the ICU people, and I give it in different emergency lectures in July. I give it in this course. So, and every time I hear the rapid shallow, it's coming from somewhere. It's like rapid deep breathing. So these patients are breathing. Sometimes I even get consulted in the ED for dyspnea, and this is not really dyspnea. This is the breathing. And when you see that, you will know this is acidotic patient, either renal failure or a DKA that has acidosis, and he's trying to compensate. This patient is breathing a liter every breath and breathing 40 per minute. So his minute ventilation is 40 liters per minute. So if you leave it to the RT to control it, usually they love the setting, 500 tidal volume, 16 respiratory rate. So patient with cosmal breathing, if you intubate them, I usually never intubate patient with DKA for low pH. These are young people. If the patient can protect airway and conscious and doesn't have pneumonia that preceded DKA or so, not hypoxemic, I usually don't intubate them, regardless of the pH. Even if 6.2 pH, I don't intubate them. The treatment of DKA with acidosis is insulin and fluid, not intubation, right? So, but if you intubate them, he's not able to protect airway, altered mental status, and you put them on the 500 and the 16 respiratory rate, this is 16 times 0.5 liter will be 8 liters. So if your pH was 6.7 and you intubated the patient for the acidosis, which is incorrect to intubate for just the acidosis, and he was breathing 40 liters per minute and CO2 is 10 to compensate for the low bicarb, then once you paralyze them with succinylcholine, this is the shortest paralytic that we usually use, and they will be paralyzed for 30 minutes. If you paralyze them, put them on 500, 0.5 liter, and 16 respiratory rate, this patient pH will be 6 in 30 minutes. Because he's paralyzed, he will follow your ventilator set. So if you paralyze the patient, you need to put them on high tidal volume. I usually start with 15 ml per kg ideal body weight. Put them on high rate. I usually start with 35 respiratory rate to simulate the cosmal breathing that they are doing. But if you start the proper treatment, which is insulin and fluid, their pH will correct because of the improvement of the bicarb when the DKA resolves. If you leave them for 24 hours, I think option E is high tidal volume, but on high flow and or auto flow and 24 hours. After the DKA correct and you are hyperventilating, they will become alkalemic, especially in kids. This can cause cerebral edema. I will talk about that more in details tomorrow. So the proper setting is high tidal volume, 10 to 15 ml per kg, and high rate. I usually start with 35, and you need to use high flow. Okay, why high flow? They are air hunger. So if you use low flow for them, they will be stacking. Stacking means taking 2 breaths at a time, and this can cause asynchrony with the ventilator. And or if our ventilators here run autoflow, that's okay. And for 2 hours, then assess. If your pH is 7 or higher, just switch into the 8 ml per kg ideal body weight and rate in the teen up to 20. So high tidal volume and high rate, high flow or autoflow for 2 hours, A is the correct answer. And most of you answered correct. I have the final is 91% answered for A. Great, I'll clear the responses. We'll go to the next question. Static lung compliance. This is a little bit difficult, so if you don't know it, that's okay. So static lung compliance is tidal volume in milliliter over plateau pressure minus PEEP, or plateau pressure minus PEEP, or over tidal volume in milliliters, or tidal volume in liters over plateau pressure minus PEEP, and D, this should be D. So plateau pressure minus PEEP over tidal volume in liters, and E is tidal volume and plateau pressure. So send your answer. Let me correct this one to D. Okay, so what's your answer? Send me your answers. Okay, as I expected, let's wait for more answers. Okay, that's okay. Okay, I have all the options are answered. So I have option E went away. Okay, so I have C 40%, 20% for A and B and D. So it is mainly tidal volume in milliliter over plateau pressure minus P. Okay, so if you have tidal volume is 500, plateau is 15, and P was 5, this will be 500 over 15 minus 5 will be 50. And normal is close to 100. So the higher the better, the more compliant the lung. So this is tidal volume in milliliter over plateau pressure minus P. A is the correct answer. I'll clear the responses and we'll go to the next question. Question number 10, which of the following increase peak pressure without affecting plateau pressure? This is one of the things that you will be called about regarding ventilators in July when you are on ICU call as a senior resident. They will tell you the pressure is high, and we'll talk about peak pressure and plateau pressure. Which of the following increase peak pressure without affecting plateau pressure? Okay, this relatively hard question. Send your answers. We have pneumothorax, we have pleural effusion, we have tense ascites, we have ET tube on the right main stem, and we have size 6 ET tube. So which answers would you like to go with? Okay. Okay, so we have, I expected this will be a hard question. So I have 45% for D. I have, things are changing, so people are still sending. Okay, so I have 50% now for D, 33% for E, and 17% for A. So E is the correct answer. When we are talking about increase in the peak pressure without affecting the plateau, we are talking about airway problem. And ET tube is part of your airway. So if your ET tube size is small, this will make your airway more narrow. So we are talking about things that can affect the peak pressure without affecting the plateau pressure. This is airway problem or ET tube problem. So E is the correct answer. I will clear, then I will get you the next question, which is the opposite. So it's asking about increase in the plateau pressure. Which of the following increase plateau pressure? This may be easier after we answered the previous question. So start sending your answers. Okay. I'm still getting more answers. Okay, so I have 90% for A and 10% for C. So A is the correct answer. ARDS will increase your plateau pressure. And when you have increased plateau pressure, definitely you will have higher peak. Because as I will talk to you tomorrow, I just will give you an example. Your peak pressure is your head, your plateau pressure is your shoulder, okay? So if you stand, your shoulder will be higher and head will be still higher because your head is always above your shoulder. That makes sense? So ARDS, all the others will increase the peak pressure, will not affect the plateau pressure. So the correct answer is A, the ARDS. Most of you got the answer correct. Okay, next one about weaning of the ventilator, what we call RSBI or rapid shallow breathing index. How do you calculate it? So these are your options. Pick your option and send your answers. Okay, everybody sent his answer. Okay, still getting some answers. We'll give you a few seconds more. Okay, I have all over the place. Maybe this is a little bit difficult one. It is mainly respiratory rate over tidal volume in liters. So this is D is the correct answer. I have only 10% for D, 10% for A, 40% for B, respiratory rate over the tidal volume, but they have it in milliliter. It is actually in liter respiratory rate. So if your patient at the end of the trial breathing 20 and he is breathing 500 ml every breath, this will be 20 over 0.5. So this will be 20 over 0.5 will be 40. So tidal volume in respiratory rate over tidal volume in liters, D is the correct answer. I will clear the responses. Then we'll give you another question about RSBI. So patient is okay to intubate if the RSBI is, which one of those that you are looking at the number to say that based on that, it's not the only indicator to extubate the patient, it's one of the parameters. So we have one option that was picked by some of you. I don't know if one person sent it or more than one person started to have some other options. Okay, continue to send your answers. Okay, so I have 88% for A and 13%, changing now 90% for A and 10% for C. A is the correct answer. Okay, so 105 or less is better. The less is better because this tells you that the patient is not breathing fast and he's putting good tidal volume. Make sense? So 105 or less is okay, and the lower the better. I've cleared the responses. We'll go to question number 14, which is the following does not decrease ventilator-associated pneumonia. These are your options. So this is a negative question, which does not. Usually when I write question for critical care, for like something like the IT exam, we don't like the negative question like this question. But for the sake of education, I'm a little bit breaking the rules for writing the questions just for more educational things. So I have 44% for C, and actually now 40% for C and 40% for E, and 10% for A and B. Okay, so somebody is thinking E, somebody, okay. So the correct answer is the frequent change in the ventilator circuits may actually increase your ventilator-associated pneumonia. So E is the correct answer. This does not reduce your VAP. But head of bed elevation, 30 to 45 degrees, and actually they love that question in the board. They ask you about what's the most cost-effective thing that reduces VAP. It is the head of bed elevation, 40 to 45. Our beds here in the ICU, you have this mercury thing on the side of the bed, and this mercury thing can tell you about the angle of the head of the bed. So every time you have a patient on ventilator, even on CPAP or BiPAP, look at this side of the bed to see what angle is the head of the bed. If it is below 30, please increase it, because this is the most cost-effective to reduce ventilator-associated pneumonia. Daily sedation holiday reduce the VAP because when you give them the daily sedation holiday, they don't go into deep sedation. So when they are ready to extubate, they are not very somnolent and not breathing on their own. So you have to give this daily sedation holiday. So subglottic continuous suction also reduce the ventilator-associated pneumonia because this will suction all the secretions that are coming from the oropharynx above the cuff of the AT tube. Proper oral care with chlorhexidine also showed that it reduced the VAP. Okay, I'll clear the responses, then we'll go to the next question. This patient is ready for spontaneous breathing trial and extubation. Which one you think? We have A, B, C, D, and E. Read the answers and send your correct answer. Okay. I'm fluctuating between two options. I got a third option. So I have 70% for D and 18% for C and 9% for A. So the patient that's ready for So for readiness, you need a patient who is not on too much PEEP, not much FiO2, able to deal with the secretion, strong cough. And so C is not correct because they don't have cough leak. And if you extubate them, they will have stridor. So C is not correct for whoever answered C. PEEP of 10 is high, so B is also not an option. 70% FiO2 for A is high, so he's not ready to be extubated. So this patient is PEEP of 5 and 40%. I like that, but he has copious secretion and he is weak cough, not able to clear secretions. And when we say copious secretion on ventilator, patient that you need to suction every hour. Okay, so this is patient has a lot of secretion. Sometimes I extubate the person if he has good strong cough, but this patient does not. D patient on PEEP of 5, 40%, although he has moderate secretion, but he has good cough, he can clear the secretion after you extubate him. So D is the correct answer. Great, I'll clear the answers and we'll go to question 16. Patient with ARDS and worsening hypoxemia on ventilator, which is the following does not. Another negative question, but for the teaching purpose, it's okay to use a negative question. Which option does not improve the hypoxemia? Send your answers A to E. Okay, I have 2 options picked. I have 3 options. Okay, everybody sent their answers. I have 71% for B, 14% for D, and 14% for E. Answer D is a little bit strange. You don't think increasing FiO2 will help your hypoxemia? So, and people who answered E, it's good that we don't have fellows on the, you don't think a fellow will be helpful to call them to help you managing hypoxemia on ventilator? Okay, actually, I will start with option E. Option E is mandatory. If you have somebody who's hypoxemic on ventilator, you have to call the fellow. And if you need the fellow to come, ask him to come, okay? So option E is not correct. I hope this will help the oxygenation, okay? So the one that was picked by 63% is increased tidal volume and respiratory rate will not improve the hypoxemia, but will improve what? What will get better with increasing the respiratory rate and tidal volume? Yeah, carbon dioxide. Great. So, but increasing the PEEP will help, increasing FiO2 will help. I hope calling the fellow will help. And you need to quickly go and assess your patient. This is mandatory. Somebody is hypoxemic on ventilator, don't manage from the call room, please. And call the fellow immediately when you are walking to him or immediately after you go and assess him. Okay, 17. For patient in ICU, based on 2018 pain and sedation guidelines, we have 2018 is the last guidelines for pain and sedation in the ICU. Which option is correct? Read the options and send me your answers. Okay. I don't know if one person or more sent the correct option, but I got the correct option 100%. Really? Everybody knows this question. This is a new question that I modified this year compared to previous years. So have 100% for A. Pain should be assessed periodically and pain medication should be started before sedation. Good answer. No pain medication is required is incorrect. So even with the sedation, actually they tell you start the pain medication before you start the sedation to be sure that your patient pain is controlled. Actually, propofol is preferred over benzo and the Precedex is preferred over the benzo. Then you should not start haloperidol or haldol as a prophylactic. You start it only for treatment of delirium. Great, I will clear the response. Then we'll go to the next question. Now we'll move to sepsis and septic shock. In sepsis and septic shock, proper antibiotic management is which option? I'm talking about, make it easy for you. What's your time frame to give the antibiotics? Is it ordered or given? So I have 2 options, 3 options, really. Okay. Okay, now I have the correct answer is increasing. One option went away. Another option is increasing a little bit. Okay, I have 78% for D and 22% for B. Let's read B first. Appropriate antibiotics given within 6 hours and 2 blood cultures drawn before giving the antibiotic. So, okay, so B actually 6 hours is a lot. And even the 2016 guidelines say 3 hours. Then the 2018 modification of the 2016 guidelines says 1 hour. And this is based on studies. Every hour after the first hour delay in your antibiotic will increase your mortality in sepsis and septic shock by 8%. So if you wait till 6 hours to give the antibiotic, then you lost 5 times 8, 40% of your patients. So antibiotics should be given within 1 hour, not ordered. So if you order, you need to talk to the nurse. And I will tell you when I talk about septic shock, I had a nurse who had potassium replacement 40 milliequivalent over 4 hours, and she didn't have enough lines, so she was giving the potassium, leaving the vancomycin on the shelf, not giving the vancomycin to the patient, waiting 4 hours. 4 times 8, this will be 32 increase mortality of your patient just by giving the potassium that you ordered and leaving the antibiotic on the shelf. So 1 hour is your time frame for sepsis and septic shock for your antibiotic to be given. In septic shock, based on sepsis campaign, initial fluid bolus for resuscitation is, this is easy one. I see people started immediately to send some answers. I have only one option. Anybody else would like to send different option than the one that was picked? Okay, I have 100% for 30 ml per kg of normal saline or LR. So this is the correct answer. And I have 100% answered this question correctly. Okay, in septic shock, the proper sequence of management is, I'm talking about which one you should you start fluid first or antibiotic first? Should you send the cultures first? Then should you start the pressor before the steroid or the steroid before the pressor? So this is the sequence. Put the proper sequence that you should manage your patient with septic shock, and we'll have the septic shock as part of the shock management on the last day, on Thursday. This will be the last lecture. I have 2 options going on now. B, D. Okay, so most picked B, fluid, then send 2 blood cultures, and then start your antibiotics. If your patient is still hypotensive, start pressors, and then add steroids if pressor requirement is increasing. B is the correct answer. I will clear the responses, and we'll go to the next question. Okay, goal blood pressure in septic shock is, this is an easy question, so send your answers. Okay, so I have 100% mean arterial pressure 65. Wonderful. This is the correct answer. We go with mean pressure because usually the patient with septic shock will have very low diastolic blood pressure. So we go with systolic blood pressure. You will not have a map that is enough to feed all the organs that you have. So map is the thing that you need. Higher than 65, data showed it will not change the outcomes and may increase the pressors required. Okay, I will clear the answer. Go to question 22. Target urine output in septic shock is? Send your answers with the options. On 5 to 1 ml per kg per hour, 50 ml per kg per hour, 300 ml per day, 1000 ml per day, more than 1 liter per day. So I have also correct answer. Looks like we had the good reading about the septic shock. So the correct answer is A, 0.5 to 1 ml per kg. So if your patient is 100 kilos, if he is less than 50 ml per hour, then he is oliguric. Okay, so 91% answered A, which is the correct answer. D, 1 liter per hour. 1 liter may be enough for somebody who is tiny. So he's probably 1000, so over 24, this is like 20 ml per hour or so. So if your patient is 40 kilos or less, this will be enough. But if they are larger than 40 kilos, the liter per day is not enough. Okay, I'll clear the answers. We'll go to the next question. In septic shock, we should monitor This is an easy question, but I meant to tell you what you need to monitor. I just was in a workshop for question writing this year and last year, and they say, please don't put in the question what you answered. Answer E. All of the above or none of the above is not preferred when you write a question. But I just wanted you to know that you need to monitor the volume status of the patient, lactic acid, especially if it is high, urine output, and blood pressure. So all the above are correct. I'll clear the responses. We'll go to question 24. First line pressure. I already got, I don't know if I will clear the responses, send your answers again because I got some answer. Okay, so first pressure to start when patient has septic shock. Okay, I have 100% for one option, norepinephrine. Which patient was shocked that you need to start epi?
Anaphylactic shock.
Anaphylactic shock, excellent. So norepi is the #1 pressor for patient with septic shock. I'll clear the responses. We'll go to next question, 25. Hospital-acquired pneumonia is defined as. So the definition of hospital-acquired pneumonia or HAP. Read the answers and send me your answer. Okay, so I have two answers, A and C. So pneumonia that develops 48 hours or more after hospitalization, A is the correct answer. I have 50% for A, 50% for C. Pneumonia after 2 days on ventilator, this is C. Okay, pneumonia and a person who was hospitalized within the last 33 months, I have 3 months. I have 44. This is HCAP, and there is nothing called HCAP anymore. So now they put it in the community-acquired pneumonia. So C, who answered C, this is a healthcare-associated pneumonia, and there is nothing since 2016 called healthcare-associated pneumonia. This went away. We didn't know what to do with it until 2019 guidelines came, and they put it as community-acquired pneumonia with risk for MDR. So, but they will have, when you talk about pneumonia, will have different definition. So A is the correct answer. I will create the responses. 26, which of the following is not at risk for MDR? This is 2016 guidelines for VAP. All of those are risk for MDR except one negative question also. But for the education, I put the things that increase the risk for multiple drug-resistant pathogens. And this may be a difficult question if you didn't read this article, but you need to know that, and we'll talk about that more in the pneumonia. So I have most for A and have C and E. So we are a little bit 50% for A. And actually, okay, let me give you the answer. E is the incorrect answer. So I have 11% answered E, which is correct. Oral antibiotic in the last 90 days is not risk for MDR. IV antibiotic, not oral, in the last 90 days is the risk for MDR, not oral antibiotic. ARDS is a risk. 5 days or more in the hospital is a risk. Acute renal replacement therapy is a risk. Septic shock on the time of ventilator-associated pneumonia is a risk. So E is not a risk for MDR. I'll clear the responses and we'll go to the next question. In VAP, the proper antibiotic should cover. These are your options, A to E. Send your answers. So I have, okay, up till now I have, okay. Okay, I have two options that were sent to me, A and C, 60% sent A and C is 40%. Actually, when we talk about that in the pneumonia lecture tomorrow, for VAP, you have to double cover Pseudomonas. Double cover Pseudomonas, not, so MRSA and double cover Pseudomonas, option C is the correct one. Option A is Pseudomonas and MRSA, but I want you to know that it is double cover. For HAP, it is conditional. Do you need to double cover Pseudomonas or not? And we'll talk about that tomorrow. But for VAP, you don't have options. You have to double cover Pseudomonas and cover MRSA. I will give you, based on this question, another question. Just give me the antibiotics to see which antibiotic, which option. So for patient with VAP, what will be your antibiotics? I want you to pick an option that will double cover Pseudomonas and cover MRSA for pneumonia. I have some answers. Okay. So I have all the answers picked C. So levofloxacin, piptaz, and vancomycin. Levofloxacin, piptaz will cover Pseudomonas. Vancomycin will cover the MRSA. So we have two antibiotics for Pseudomonas. Here, azithromycin doesn't cover Pseudomonas. Here, another option here is daptomycin is not good for pneumonia in the lung because it's deactivated by the surfactant. So any option that has daptomycin for the lung. So for the MRSA pneumonia, you have to use either the vancomycin or the linezolid, okay? Okay, I will clear the answers and then we'll go to the next question. We'll move to something different, transfusion in the ICU. What's the cutoff to transfuse a patient who is stable and asymptomatic in the ICU and does not have acute angina or MI? Easy question. I have some answers for one option. Anybody else would like to pick different option? Looks like everybody picked the correct option, which is option C, 100%. Great, so 7 grams for stable patient who is not actively bleeding or symptomatic with no acute MI and no unstable angina. So I'll clear the responses. Then we'll go to the next question. TRALI, transfusion-related lung injury definition is, send your answers. These are your options. Although it's getting more rare now, but we see that a lot in professor rounds and resident conferences in the cases that you present. TRALI versus TACO versus, okay, I have 89% picked B, acute lung injury during or within 6 hours of transfusion, and B is the correct answer. So I have 80% for B, 10% for C, 10% for E. So it is during or within 6 hours, so B is the correct answer. Great. I'll go to the next question. We'll talk a little bit, a couple of questions about hyperkalemia. First step, so the nurse called you when you are on call and told you, okay, I had the potassium is 6.7, but I think the sample is hemolyzed. What's your best reaction to that? Okay. And I'm talking about the first reaction. What's the first step in management to do? Have the 60% for A and 40% for C. So C is the correct answer, order EKG and reviewed. Even if she told you that the sample is hemolyzed, you don't know, right? If it is real. So order EKG, and when you order EKG, you have to go and look at it. A few years ago, we had a patient, they thought it's hemolyzed, didn't do anything, just repeated the lab, and a few minutes later, patient coded, okay, from hyperkalemia. So any abnormal potassium, take it seriously. Please go and get EKG to see if there's any EKG changes for hyperkalemia. And if not, wait for the repeat lab. But if it is high, you have EKG changes, start management. And the question, if you have EKG change that suggests hyperkalemia, what's your best management or first management? Send your answers for question 32. Okay, for the sake of time, I have 100% for A, calcium gluconate, IV in peripheral line. The reason we don't give calcium chloride IV in peripheral line, it is very irritant. Calcium chloride is correct, but usually should go in central line. All the others will help, but first step is to protect the myocardium from going into VTAC or so. Okay, hypo and hypernatremia and chronic asymptomatic hyponatremia, goal for sodium correction is, and this is based on your guidelines. So, okay, most of the answers are going for B, some are going for E. E is old guidelines, 12 milliequivalent per day. We go now with 4 to 6 milliequivalent per day. Okay, chronic asymptomatic, you don't have to go fast, the 20 is a little bit fast. So the recommendation now 4 to 6 milliequivalent per day. I will clear the responses and I will go to the next question. For cardiac arrest patient, what should you do? These are your options. And this is the easy question I told you about that we shouldn't use when we write questions. Wonderful, everybody picked the correct thing. All the above. So we need to assess code status, consider temperature targeted, like temperature targeted protocol. Then you need to update the family after you stabilize your patient. Then you need to call the fellow, and this is one of the requirements for our fellows here in Truman, that they should come. If you have somebody with cardiac arrest, especially if they are not doing well, call the fellow to come, and they should come. And we discussed that for like few weeks ago, that new fellow didn't come, and we told the fellow you have to come for somebody with cardiac arrest to help the rest. Okay, question number 35. So patient had high probability of PE, but you want to send him to CT angio. They told you CT angio, now we have trauma, major trauma, and we will not be able to do the CT angio for 1 hour or so. What's your proper management steps? And I like whoever sent B answer. Anticoagulate, don't wait for patients with high probability. D-dimer is not meant for high probability PE based on the Wells score. This is meant for low and moderate probability. So don't wait. Somebody wanted to wait for the CT. Your patient may die during this hour waiting. So I would start the heparin drip, then you can stop it after you get the CT, especially if your patient doesn't have any anticoagulation contraindications. Okay, so B is the correct answer. Okay, in treatment of pulmonary embolism, the following medication need 5 days overlap with heparin and therapeutic INR for a couple of days. Which one? Wonderful. Somebody sent the correct answer already. Now I had all the above and none of the above, but this is not the correct answer. So everybody picked warfarin. So Coumadin is the one that requires overlap for 5 days. The Eliquis and Xarelto or apixaban and the rivaroxaban does not require any overlap with heparin. Great. Next question. The strong indication for thrombolytic in PE is? Wonderful. Shock from PE. So this is the strong recommendation. I have somebody answered D, right ventricular strain in echo or CTA. This is submassive PE, and this is controversial for anticoagulation. Pulmonologists, ICU say no. Cardiologists say go ahead and give the lytic, but this is controversial. But the A, everybody would say give the lytic. So A is the correct answer. Last 3 questions. DKA. All of the following are indicated in DKA management except. Okay. Okay. I have E and I have some people are answering C and D. Let's talk about C, potassium replacement. If potassium is less than 5.3, this is required. And delaying the potassium, if you're delaying the insulin, if your potassium is less than 3.3, this is the requirement. If your potassium is 3 or 2.5, don't start your insulin, because once you start your insulin, this number will go down and you will get some arrhythmias from the hypokalemia, okay? So you need to replace the potassium first before you start your insulin if your potassium is below 3.3. So bicarb is the correct answer. Some people go with the bicarb if pH is 6.9 or less. I usually don't like bicarb at all for DKA. So, but this will be the correct answer that you shouldn't do if you're the bicarb if your pH is 7.1. Stop IV insulin in DKA 1. So what's your option to when do you need to stop your IV insulin? I have answer for A, anion gap close and overlap with sub-Q insulin. This is the correct. What's the half-life of insulin? Anybody knows? IV insulin half-life is
2 hours or?
Somebody is saying something, but I didn't hear it well.
Is it 2 hours?
2 hours.
2 hours. Okay, it's 6 to 7 minutes. Okay, 6 to 7 minutes half-life. Which has longer half-life, the regular short-acting insulin or the Lispro?
Regular.
It's the same. IV is the same. There is difference in the sub-Q, but IV, they are the same. So that's why we use the regular is cheaper, but you can use the Lispro. There is no difference in the IV half-life. So half-life of IV insulin is 7. If you don't start sub-Q insulin after 30 minutes, you have 0 insulin in the patient body, and they will have 500 blood sugar again, okay, in 30 minutes. Great. Last question for stroke. What's the time frame to give thrombolytic with alteplase after exclusion of contraindications? What's your frame? Okay, I have the answer of C. This is the correct answer, 4.5 hours. Great, so I'm done now with the 40 questions. And anybody who has any questions before we move to the, I'm still getting the C answers, which is correct, thank you. Okay, anybody has any questions about these 40 questions that we talked about? 40 questions with 40 informations I wanted you to learn about in 45 minutes. We are 4 minutes behind, but we are okay. Any questions? Wonderful. If no questions, let me move. I will stop sharing the screen and I will share the screen with you in a different thing, which is the PowerPoint for the ventilator, for the non-invasive positive pressure ventilation. And please let me know if you see my screen. Looks like everybody see my screen. Also, please let me know if you if my slides are not moving. Don't wait for a long time, because this happens sometimes with the Zoom, that the slides don't move. Okay, we'll talk about non-invasive positive pressure ventilation, and abbreviation for that. 2 abbreviations are correct, NIPPV or NPPV. So both are correct. You see both in the literature, so they are both correct. Okay, I have no disclosures. Objectives by the end of this 45 minutes, we recognize indication and contraindication to put somebody on non-invasive positive pressure ventilation. We will not need to know how to manage and adjust the setting for non-invasive positive pressure ventilation. And I will have some questions later on. What do we mean by non-invasive positive pressure ventilation? Is positive pressure ventilation that's using a mask. And this mask can be variable types, and another name you may see in the literature is interface. Interface, we mean by that the mask. These questions, I want you to think about it. These are things that I get questions a lot, and I added this is a new lecture, first time to do, because I got multiple requests to have some education about non-invasive positive pressure ventilation management in the acute illness. What diseases benefit from non-invasive positive pressure ventilation? Does it help COPD exacerbation? How about asthma exacerbation? Does it help pulmonary edema? Does it help pneumonia? Does it help ARDS? When to start non-invasive positive pressure ventilation in the acute settings? When to start the non-invasive positive pressure? This patient, oh, we need to put him on non-invasive positive. What mode should you use, CPAP versus BiPAP? BiPAP is written BPAP. There is no I in it. The BiPAP is a mode in a certain machine. So BiPAP, what we say BiPAP is BPAP, not BiPAP. Or EVAPs that we have here, and we use it a lot. What mask works best? What setting should you start? Does BiPAP setting differ in patients with sleep apnea? If CO2 is high, would you correct to 40 for every patient? What can you extubate a patient from ventilator to BiPAP or EVAPs or CPAP? What to do when the patient refuses the non-invasive positive pressure ventilation? So somebody is very sick and he's refusing. You need to do something, because if he doesn't use it, he may be on ventilator in the next few hours. Then others, based on what you think you would like to know from me about the non-invasive positive pressure ventilation. I'll start talking about the different types of masks very quickly. Oronasal is a mask that covers the nose and mouth. We call it face mask sometimes, oronasal. Nasal, cover the nose. Nasal pillows or prongs that they go inside the nose. Okay, they look like the mustache with some prongs or pillows that go inside the nose. Then the full face mask, or we call it hockey mask, is a mask that covers from above the eyebrows, nose and mouth. So this is what we call full face mask, different from the face mask that cover the mouth and nose. Then the last one is the helmet. Anybody saw the helmet mask? Helmet mask is like the helmet that is used. Sometimes there's some studies about it also in the COVID. This is something that you can use. It helps more the hypoxemia, but not the hypercarbia. This mask, the patient can talk with it and can even drink through a straw through the mask. Doesn't have the problem with any pressure ulcers on the face of the patient. So give you better oxygen and better PEEP, so to help the hypoxemia. The drawbacks, it can accumulate carbon dioxide, can worsen the patient carbon dioxide. Because the noises of the ventilator is around his ears, they can get some hearing damage. You want some tidal volume, but the patient may not get exactly the tidal volume based on the distensibility of the mask. So helmet is used in COVID and showed some response. This one is a nose mask, cover the nose only. This is one is the oronasal or face mask, cover the nose and mouth. This is the hockey mask, okay? You see, it covers from the forehead all the way down. This is probably a little bit rarely used, some oral mask. And this is the helmet, how it looks like. I'll give you another picture of the helmet. You see this patient is inside, and this is how it looks like, okay? Different positive and negative for everyone. Nasal mask is the most tolerated by patients who are claustrophobic. So you have claustrophobic patient cannot tolerate the oral nasal mask or the face mask or the helmet mask, then you may need to use the nose mask. The drawback for that, patient can open the mouth and have some air leak, okay? What's best? Many studies compare different ones. For the sake of the time, you can read these studies if you are interested to read them, but I'll give you the conclusion. If you have patient with hypercarbia, so hockey mask or face mask are okay, but not the helmet. We said the helmet will increase your carbon dioxide. So don't use the helmet for patient with hypercarbia. If you have hypoxemia, the best that showed improvement is helmet, but all others are good for hypoxemia. So nasal mask, oronasal mask, even the nasal pillows can help the hypoxemia as long as your patient keeps his mouth closed. So the best mask, you see this is in red, the best mask is what the best tolerated by the patient. So if your patient can tolerate some, even if they tolerate the helmet mask and they are hypercarbic, maybe it's okay. So if they use it for few hours, better than nothing, okay? So the best tolerated, and you need, one of the things that you need to do to try different masks for patients who is not tolerating your CPAP or BiPAP. Okay. How tight? You put your mask, you need to be able to pass one finger between the patient head and the straps. So one finger is okay. This is how tight you need to keep your mask. For patients with claustrophobia, you can use the nasal mask. We don't have the nasal pillows here, but we use the nasal pillows a lot for patients with sleep apnea and the sleep clinic. And if you use that, if you want to use chin strap, if your patient is mouth breather, if he has a large leak and he is sleeping with his mouth open, then you can add chin strap. This chin strap will keep the mouth closed when they are using the nasal mask or the nasal pillows. You need to assess allergic rhinitis. May not be the best in the acute situation, but for patients in sleep clinic, I always ask them if they have any sinus allergy and treat it, because sinus allergy is one of the major things that make the patient intolerant to the CPAP or BiPAP. Humidification, yes or no, cold or heated. In patients with sleep apnea, heated humidity helps to get better use of the machine. In our inpatient machines, if you use heated humidity, you can add it to the machine. But if you use it, be cautious, because some patients complain that they're getting too much water with it. It's different from the small CPAP machine at home. But heated humidity is one of the things. We use also heated humidity for patients with the airflow. All of you probably use airflow for COVID patients. So heated humidity is one of the things that may help the tolerance for the machine. CPAP versus BPAP versus average volume assured pressure support, or what we call AVAPS. Okay, this is the CPAP. You put a certain specific pressure. So here we have the patient on 5. When he starts the breath, he will create negative pressure. The pressure will go a little bit less than the 5. When he exhales, the pressure will be exceeding the 5, but he will be around the 5. For BPAP, you will have IPAP and EPAP. So IPAP, so this patient is on IPAP, on BiPAP 10 over 5, so his IPAP will be 10 and his BiPAP will be 5. Okay, contraindications, and I always like to start with contraindications before the indication for any medication or any instrument. When not to use the non-invasive positive pressure ventilation, you need to intubate them. Patient with cardiac or respiratory arrest, somebody who is coded and he is not able to wake up, then don't use non-invasive positive pressure ventilation. Non-respiratory organ failure. So if patient has some acute encephalopathy, hepatic encephalopathy or something, the only encephalopathy, mild to moderate encephalopathy from hypercarbia that may get better with the BiPAP is not a contraindication, but any other encephalopathy is not. Anything coming from the nose or the mouth, CSF leak, epistaxis, hematemesis, vomiting are contraindication to use non-invasive positive pressure ventilation because they can aspirate. Somebody with trauma, especially if you have CSF leak, they have cribriform plate fracture. If you use the non-invasive positive pressure ventilation, you may push the bacteria from the nose to the CSF. Patient may have pain in his face, and having a mask on his face will be some torture for him. Upper airway obstruction, don't use your non-invasive, somebody with angioedema, somebody with laryngeal mass. So patient was not able to protect his airway, not able to clear his secretion, high risk for aspiration, like somebody with gastroparesis, somebody's coming with vomiting, hematemesis, is contraindication. Indications, acute or acute on chronic respiratory failure, especially in COPD, pulmonary edema, obesity, hypoventilation syndrome, neuromuscular disease. These are patients can benefit. Chronic respiratory failure, sometimes we use those at home. Somebody with COPD, neuromuscular disease, it's definitely sleep apnea and obesity, hypoventilation syndrome. Sometimes we extubate patients from ventilator immediately to non-invasive positive pressure ventilation, and we'll tell you what are the best patients to extubate immediately to BiPAP or so. This is from up to date. When you start CPAP, I usually start CPAP very low pressure. Even if it's not enough, patient is naive to the pressure. I don't know if any of you put a CPAP machine on his face, tried it. Even with pressure of 5 or so, you will feel very high pressure in your face. So it is not an easy thing for the patient. I usually start with the lowest pressure and see how they can tolerate and then gradually go up. Even when I start the CPAP, I ask the patient to hold the mask with his hand. I don't strap it immediately, so the patient will feel that you put something on his face, pushing high pressure, he's not. But if he holds it with his hand, then ask him to push it more tight until it is not leaking. Then once he gets used to it, I add the straps. BiPAP also, I can start with low pressure, like 8/4 or 10/5, and then titrate up gradually for patients specifically if they are naive to the machine. Okay, how to manage your CO2 for your patient on BiPAP. So your patient is hypercarbic and you want to improve the carbon dioxide. How would you do that? The difference between the IPAP and the EPAP, what we call the pressure support. So if you put him on 10/5, the difference is 5 between the 10 and the 5. And this is your pressure support. This is what gives you the tidal volume. So this is very important because don't put him just on 10/5 and leave him because he may not be getting enough volume to be able to wash the carbon dioxide. Then gradually increase the IPAP by 2 until you reach your tidal volume. We usually would like an average 6 to 8 ml per kg ideal body weight in patients with COPD, which is most of your patients that will come with hypercarbia. So you wanted your patient to be on 500 tidal volume. This is his 6 ml per kg ideal body weight. You wanted 500. You put him on 10/5. He's getting 300. Go from 10 to 12, 14, 16, 18, until you reach your tidal volume that you want, the 500. Make sense? If you need to increase the APAP for any reason, so you reach that he got the 500 with 15/5, but he is still hypoxemic, and you want to increase the APAP to help the hypoxemia. So went from 5 to 7. You need to increase the 15 by the same amount to 17. Make sense? So keep the difference that give you the tidal volume you want. Okay, how to manage low oxygen. So your patient is starting 80% on your BiPAP. You start at 10/5. He is hypoxemic. You can increase the PEEP, which is the EPAP, or you can increase the FiO2. So if your patient you start at 40% hypoxemic, you can go to 50%. You start at 10/5. He is hypoxemic. You can go to 7 instead of 5, but increase the 10 to 12. So whatever you increase in the EPAP, you should increase the IPAP the same amount so you can keep the difference the same to keep your tidal volume the same. This is the AVAPS, and we use that frequently here in the hospital. So what's the AVAPS? So instead of standing beside the patient titrating the IPAP to get the tidal volume you want, you just can say, okay, machine, please, I want 400 tidal volume. I want 500 tidal volume. And you put a range for the IPAP, and the machine will do that for you. I usually start EPAP of 4, unless the patient has sleep apnea or so. IPAP minimum, EPAP plus 2. So if you started at 4, should start with 6. IPAP maximum, don't worry about it. Our V60 machine goes up to 40. And I usually go to the 40 when my patient is obese, because you need higher IPAP to probably expand the lung and get the volume you want. If your patient is very tiny, you can start with 25 IPAP maximum. But if you start IPAP 40 for every patient, IPAP maximum 40 for every patient, you will not be wrong, okay? So you will not harm your patient. So this is okay to keep your IPAP for everybody is 40. Usually tidal volume 6 to 8 ml per kg. If your patient has COPD, neuromuscular disease, I usually start with 8 ml per kg ideal body weight. If your patient is like COVID with ARDS, I start with 6 ml per kg ideal body weight. Then low rate in the low teens, because you want your patient to control it. One of the things that can make your patient intolerant to the machine, if you put him on fast rate, 25, his CO2 is high, and you want to watch the CO2, faster rate will help the CO2, but your patient is naive to the machine. If you put him at 25, he will feel the machine is pushing very, very fast and very hard. So this may increase your intolerance, your patient intolerance to the machine. If your patient is sleep apnea, he's usually on CPAP machine at home. If he's on CPAP 10, I may start the IPAP minimum, the EPAP at 10, and IPAP minimum 2 higher than that, so at 12, and see if he can tolerate that. You will not really need the 10 CPAP pressure unless he falls asleep, which is most of the patients come with acute respiratory failure. They didn't sleep well for the previous 3 nights from the shortness of breath. And when they get comfortable on the non-invasive positive pressure ventilation, they fall asleep. This is how our machine looks like. So here is a patient that we had tidal volume. We wanted it on 560 tidal volume. So, and we started PEEP or EPAP 4, and IPAP minimum 8 and maximum 30. So IPAP will change between the 8 and 30, 25% FiO2 and rate of 60. This is what he is getting. He is getting the pressure, the IPAP is 15. He is between the 8 and 13. With the 15, this is the tidal volume he's getting, 420. Less than the tidal volume that we want. We wanted 560. What will machine will do? This machine will increase your IPAP every minute by 1 until you get the 560. So this 15 after a minute will be 16. If it is not 560 yet, will be 17. Once we got the 560, we'll stay on the same level. This is the dotted line of your tidal volume. Here, the same patient, we wanted 560, but now he's getting larger volume with the same pressure of 15. So what will happen? He may be a little bit more awake, pulling more volume, and with 15, he's getting larger than what we want. The machine every minute will reduce this 15 by 1, 14, and then we'll look at the tidal volume for several breaths to see if it is 560 or not. If not, we'll go to 13, and we'll go from there. Make sense? So the machine will change your pressure periodically to get you the tidal volume you want. This is the difference between the AVAPS machine and the BiPAP machine. IPAP will change periodically without you doing anything. You give the machine a range, and machine will change your IPAP within that range until you get your tidal volume you want. Some troubleshooting. If your patient is auto-peeping, can you get auto-peeping on non-invasive? Similar to the ventilator? Yes, you can get auto-peeping. What you need to do, you need to reduce your respiratory rate or reduce your tidal volume and see if your patient gets better. Then your patient has a lot of leak. Be sure the straps are tightened correct. Okay. Be sure your patient is not opening the mouth if you are using nasal mask or nasal pillows. And see what's causing the air leak. All the CPAP and BiPAP, they have mandatory leak. And sometimes when you are trying to examine the patient with BiPAP and CPAP, you find the hole that's pushing air out. This is a required mandatory leak to avoid CO2 retention, okay? But what we are talking about is the leak that we don't want, but the mandatory leak should happen to avoid retaining carbon dioxide. You need to improve your patient comfort and reduce his anxiety. So you need to explain, if this not a very emergent patient is about to code or something, explain to him first what will happen, how he will feel. Let him hold the mask on his hand and see how he does. Switch different masks. If he doesn't like a certain mask, switch to a different type of mask to see if he will get better with this mask. Sedation, I'll talk about that a little bit later. You can use a little bit of sedation, but be careful because this may worsen the respiratory failure. So we rarely use sedation or pain medications for patients on non-invasive positive pressure ventilation, but you still can use it. Let's do some troubleshooting for EVAPs. So we put a patient on EVAPs. This is our setting. We wanted 500 tidal volume. Started EPAP of 4, IPAP minimum of 6, 2 above the EPAP, and IPAP maximum 25, and respiratory rate 12. Very reasonable setting, especially if your patient is 10 person. But we found that with the 25, your maximum IPAP, 25, he's getting only 400 and you wanted 500. In this condition, you need to increase the IPAP maximum to 30, 35, or 40. That's why if you start IPAP maximum of 40 for every patient, you are okay. Make sense? He will get whatever the pressure he needs. Sometimes we have patients with morbid obesity, and with the 40, they're not getting the tidal volume that we want. In this condition, if your EPAP is high and he's not hypoxemic, so if your EPAP is 10, I may reduce the EPAP to 4 to give him more range, 40 minus 4 versus 40 minus 10 or so. This will give you larger tidal volume. Okay, another patient, we put him on setting tidal volume 500, EPAP 4, IPAP minimum 12, IPAP maximum 25, and respiratory rate of 12. With the IPAP 12, which is the IPAP minimum, he is getting larger tidal volume that we want persistently. I may reduce the IPAP minimum from 12 to 6, just 2 higher than the EPAP. Because maybe with the 12 is too much for him. Patient is probably tiny, does have very compliant chest wall, and with the 12, he's getting too large, and the machine is not able to go below the 12 IPAP minimum because you have the setting between 12 and 25. So machine cannot go below the setting that you put. Okay, another patient, tidal volume 500, EPAP 4, IPAP minimum 12, IPAP maximum 25, respiratory rate 12. The problem now, and 40% FI2, the problem now he's hypoxemic. How can you help his SAT? He's 85, you want him to be 88 or 90, then you can increase the 40% to 50% and see how he does. Or you can increase the EPAP from 4 to 6 and see how you do with that. Make sense? So increasing the EPAP or the FI2 will help your hypoxemia on the EVAPs. If you have any questions, please stop me in the middle, okay? Okay. When you try it for 1 to 2 hours. You put them on BiPAP or CPAP or EVAPs, put him on 1 to 2 hours and assess if he's responding or not. If he's not tolerating for that 1 hour to 2 hours, then you may need to do something else, intubate him or something, try different mask or something like that. But if you try him for 1 to 2 hours, then you assess him. This 1 to 2 hours is mainly based on COPD patients in the trials, and your CO2 should get better within 30 minutes to 2 hours. So CO2 should get better within 30 minutes to 2 hours. That's why after I put the patient on EVAPs or BiPAP for hypercarbia, I check ABG in 30 minutes. Same thing if I intubate somebody, I check ABG in 30 minutes. Okay. Patient who will have successful trial, these are the patients that will clinically get better. His respiratory rate will be less, his distress will be less, he's more comfortable. In the meantime, your blood gas will get better. Then this patient, you continue. Okay. Trial failure. If he fails the trial within 1 to 2 hours, then you need to do something else, maybe intubate him. About a third of your patient may fail the trials. Criteria that suggest failure of the trial: if your patient gas gets worse or does not improve, and more than that, the clinical condition of your patient. His respiratory rate he's breathing 40, but he's sitting fine, but he's breathing 40. He may not tolerate that for a long time. His severe distress, encephalopathy is worsening, so This is the clinical assessment for the failure. This condition, you may need to intubate the patient. Okay, he got better. You used it 24 hours. Now you are assessing him. He feels better. Everything gets better. Your gas ABG is better. Patient feels better, not in distress, and he is say COPD exacerbation or asthma exacerbation is better. The wheezing is much less after you started the treatment. So this patient that you need to assess, is he ready to wean? There are different types or different ways to wean. Your patient on high pressures, you may need to lower these pressures a little bit. Another option, to give him a break between times. And or you do the two things together, lower the pressure and give him a break and gradually increase the break. What I usually do for patients that I trial them, so patient was on AVAPs or BiPAP for 2 days for COPD exacerbation, now he feels better. I don't take him off immediately from that because his CO2 may go up again. What I do, I see if he can tolerate 2 hours off the machine. And if he can tolerate the 2 hours off, I switch him to 2 hours on, 2 hours off during the day and put him all the time at night. Be careful. You need to put RT communication and order for BiPAP. And I personally prefer that you talk to the RT and tell them that this patient needs to go back on the EVAPs or the BiPAP all the time from 9 p.m. till 7 a.m. Make sense? If he does well with that, next day I can reduce it to 4 hours on, 4 hours off during the day, then gradually switch him to all the time at night. Then if he is acute situation, he will not need a machine at home. If he's chronic situation like sleep apnea, COPD very low, FEV1, some obesity, hypoventilation, some respiratory failure from neuromuscular disease, these patients will need home machine. You need to assess how can you qualify them for home machine. Probably need pulmonary help to get that, but this is out of the window of the discussion today. Okay, critical points I want you to learn. Number one, that's in red, never restrain your patient when they are on ABAPs. Never restrain them when they are on ABAP. Your patient, can be a medical legal thing. Your patient should be able to remove his mask. Also not the best if your patient has a stroke, not able to remove your mask, okay? Why? If your patient vomits and he has full face mask and he's not able, he feels nauseous and he's not able to move the machine, then he will vomit inside the mask and the mask will push it to his lungs. Well, a few years ago, patient coded from vomiting into the face mask and he aspirated and coded. Patient position, we prefer to be 30 to 45 degrees, similar to the ventilator, but you can put him flat if you want to do central line, even Trendelenburg if you want to place central line on the AVAPs machine. Can you do bronchoscopy on the AVAPs or the BiPAP machine or the CPAP machine? Yes. Even with the mask, we have a specific adapter that we can put and do bronchoscopy. But I usually don't do the bronchoscopy unless an emergent bronchoscopy. So the only situation I do that on patient who's not able to come off the non-invasive positive pressure ventilator, they have atelectasis. And I think when I clear this atelectasis, they may be able to come off the non-invasive positive pressure ventilation. But I don't do diagnostic BL and things like that because this patient can code during that, okay? So very rare times that you can do a bronchoscopy, and a good example if you have complete collapse of the lung or one lobe collapse from mucus plugging, and you may need to do that. Sedation. This is something that's controversial. We have good thing and bad thing, and we need to balance. If you give sedation to the patient, he may be able to tolerate the non-invasive positive pressure. He may be able to tolerate the mask more and the pressure. But in the meantime, sedation can put him on worsening of his respiratory failure. So we need to balance. Never use pain medication and sedation together. The data tell you that this will get him to respiratory failure. Can you use one small dose, either pain or sedation? You can. And one of the things that sometimes we can use in the ICU is the Precedex. So this does not suppress the breathing. So if your patient is not able to tolerate the machine and he's on the ICU, you can use Precedex as a sedation. Doesn't affect the respiratory failure. Should you feed the patient when he's all the time on CPAP or BiPAP? You should not, okay? All the time is contraindication to feed him. because he may vomit. Most of the patients are naive to the machine, and big part of the air goes to the stomach, cause gastric distension. And this is very common complaint for people who, when we start them on CPAP or BiPAP at home, and they will say, okay, I feel significantly distended, I have a lot of gases. So after I started using the CPAP, because when they are naive to the machine, they swallow a lot of the air. Can you put NG tube to feed him? This can increase the risk for vomiting. Also, may affect the sealing of the mask from the NG tube. Dub half, maybe less affection of the sealing, but we still prefer, if your patient is all the time on non-invasive positive pressure ventilation, we shouldn't feed him. Can you use nebulizer or inhalers for your COPD? You can use either. Can work with them. Travel, I don't mean by travel going for like a vacation in Hawaii. Travel, I mean going to CT scan or going to do some test. Really, if your patient, the test for any patient in the ICU, the test will not affect your management. Don't send your sick patient out of the ICU, okay? If you can manage without getting this test. But if you need really the test, you can switch them from the BiPAP or the AVAPs to a portable ventilator to do the test and come back to the ventilator. Where and who, where to manage, and should you consult pulmonary or not? So if your patient all time and non-invasive positive pressure ventilation, you need to put him on PCU or ICU based on your clinical assessment, and you need to consult pulmonary, okay? If your patient is getting intermittent use, based on your assessment, does he need PCU or can we go to the floor? Do you need pulmonary or not? This is clinical assessment, I will leave it for you. But patient all the time dependent on the non-invasive positive pressure ventilation, so we need to assess higher level, don't put him on the floor, and you need to consult pulmonary. Okay, we'll start with a quick case. 45-year-old gentleman with COPD, FAB1 35%, admitted for COPD exacerbation. In the ED, they put him on 100% non-rebreather mask because his SAT was 80%, and his SAT went up from 80% to 100%. We don't like that, and we'll talk about that tomorrow at noon for the ventilator lectures, how much oxygen you need to give, what's your targeted SAT. 100% SAT is harmful to patients with CO2 retention. This is your ABG, pH 725, 85, 167 oxygen, 36 bicarb on oxygen 40%, and bicarb in the BMP is 34. He's 5'10", and he weighs 118 kilos. Should you place him on oxygen different from what they did? This patient, you need to start with 2 liters of oxygen, titrate for SAT 88 to 92%. Would he benefit from non-invasive positive pressure ventilation? Yes. Patient with COPD acute exacerbation, especially if your pH is 735 or less and CO2 is 45 or higher, this is strong indication to put him on AVAPs. So what mode should you use? You should use BiPAP or AVAPs. So this is a better mode for COPD with CO2 retention. Don't use CPAP for this patient. Would you correct her CO2 to 40? No. Why? This patient bicarb 34 tells you that his 185 CO2 is acute and chronic. If you calculate based on the 34, he's probably running 70 carbon dioxide baseline, so you correct him only to 70. Don't correct him to 40, please. Okay. This is a patient who will benefit, and this is, everybody is familiar with the GOLD guidelines for COPD. They update that every year in January or February. We have GOLD 2021. Please read it. There is pocket and full guidelines. The pocket one is easy to read. At least read the pocket. You will learn a lot. There's another guideline for asthma. It's GINA, G-I-N-A. Asthma guidelines, also they renew it every year. Also there is full and there is pocket guideline. Read the pocket guideline at least for GINA and for asthma. What did the GOLD 2021 say? If your patient was pH 735 or less and CO2 45 or higher, you should put him on non-invasive positive pressure ventilation, BiPAP or AVAPs. Also, if they have severe distress without this criteria, or if they are significantly hypoxemic, that's not correcting with the oxygen, you need to use the non-invasive positive pressure ventilation. This is a study that our fellow is presenting in the ATS. We did a retrospective study for the last 10 years comparing BiPAP and AVAPs, and we didn't have any difference in the two, preventing intubation or reducing the carbon dioxide or correcting the pH. Another case, 65-year-old man with history of chronic systolic heart failure, ejection fraction 25%, admitted with severe shortness of breath, setting 80% on room air, blood pressure 90/60, bilateral basal crackles on chest exam, gallop on the heart, and diagnosed with acute pulmonary edema. Would he benefit from non-invasive positive pressure ventilation? Would you use CPAP or BiPAP? So strong data that non-invasive positive pressure ventilation, CPAP if they don't have hypercarbia, BiPAP or EVAPs if they have hypercarbia, will improve the outcome for these patients. So mechanism, non-invasive positive pressure ventilation will reduce preload, reduce afterload, and also will prevent the collapse of the alveoli. So this is how non-invasive will help the patient. So it improves clinical and laboratory outcomes for patients with heart failure, improves mortality, reduce intubation. The question that was something that people were worried about a few years ago, would it increase MI in these patients? It will not. So
That's it for the morning, right?
I'm sorry, can you repeat that?
Okay.
Yeah, I can't hear you very well. Okay, so CPAP or BiPAP if they are not
previous
hypertensive?
recommendation was don't screen because the 2 years ago the study did not demonstrate any difference in outcome in US, but there is a study in Europe. Somehow now looks like Euro studies.
Well, I want to be a urologist, so I kind of go by the American Urology Society, but I know that's not how normal.
They updated the
Okay, I see
the
some
13
people
years
are
old
talking.
European study show that it actually
So if you are doing side discussion, please mute yourself. Okay,
so that's
so
why
CPAP,
now the
Is this
Okay.
the A1?
whoever
Reduces the risk of dying prostate cancer
Kat,
specifically.
please
by
mute
doing-
yourself.
Also,
yeah.
Okay.
So that is true.
did they have like a certain population, like certain ages?
I'm not able to mute them. Sorry for that. Anyway, CPAP or BiPAP if your patient is hypoxemic. If your patient is hypercarbic, use BiPAP or EVAPs. Okay, a lot of studies that showed improvement with pulmonary edema, mortality, ICU days, CPAP improved mortality,
Okay.
and BiPAP also improved outcomes.
It's still
Not sure if you see it.
Okay.
Anyway,
Oh,
so acute pulmonary edema, a lot of studies showed
for
improvement.
that age group.
So multiple studies, CPAP versus BiPAP, no difference in intubation, no increase in the risk of acute MI, no change in the mortality.
Okay,
of
to
CPAP or
discuss
BiPAP.
family.
No change in hospital stay.
Because there's a lot of other things, right? You look at everything.
Oh my God. So guys, if you are
Reduce
not,
all-cause mortality by
please put yourself on mute.
Absolutely no.
Okay.
That's another screen. The population.
Okay. So
So they might die
meta-analysis showed
of
the
other things too.
So they might not die of the,
Yeah.
they might not die of the prostate cancer, but they might die of
Yeah,
something
so.
else.
Dr.
it's
Gohar,
not
can you
trivial
eject
to
her
affect
from the
all-cause mortality.
able
group?
to, I'm not
Yeah.
able
A lot of
to
diagnosis.
take them off.
It's controversial whether it's useful or not, so some people stop doing it.
Okay.
Okay, prostate cancer screen is false.
An estimated of 20 to 50 men diagnosed with prostate screener by cancer may be overdiagnosed. I think
Yeah, a
that's
lot of
true.
overdiagnosis.
Between 20 and 17 screen men will have a false positive
Please, if
PSA.
you are,
I think
please
that
mute yourself if you are talking.
true.
But
It could be even
It's
higher.
not false positive, but it's because it's so mild stage, it doesn't.
Yeah, you have to.
affect all-cause
That contributes to invasive tests like biopsies. That's a common risk factor for prostate cancer. Family history, I think that is race, ethnicity.
Yeah,
I
prostate
believe
cancer
is
not public.
tobacco
Yeah, tobacco doesn't
exposure.
actually affect
Back
prostate
process.
cancer.
Okay, so patient less likely
Because then
to benefit.
age
I will
also.
go through those
does.
quickly. If you have COPD
Age
patient
of course.
with no hypercarbia, they may not benefit.
Yeah.
Acute respiratory failure with asthma, I may try it. Asthma
Yeah.
does not benefit much, but
Hey, Dr. Gohar, can you share like
Below 70,
patient, if the patient has
Can
pulmonary edema or
you still
COPD,
offer?
they may
Okay.
benefit from being
I don't
on the
have many
unit
male
You don't have
in
to
the non-invasive
them
hospital.
to it. right?
You just talk, you offer.
If your person extubate immediately to the CPAP or BiPAP,
right?
don't wait until they get
If they are
more
afraid of
failure
doing
to intubate
biopsy,
them.
post-diagnosis anxiety, I'm
Okay,
absolutely
ARDS,
One.
other than
Okay.
what we have recently where patients with COVID may not
Okay.
benefit from non-invasive positive pressure
When I
ventilation, the data is not strong.
Next time
But
I have
for
a
patients with
male
COVID
patient.
and ARDS, helmet, mask, the one that goes around the head.
Dr. Gohar, we cannot hear you properly.
Oh,
I think we have an external audience.
Yeah, I think somebody is talking. I'm not able to mute them. They stopped talking now. Do you hear me better?
Yeah, now better.
Okay.
Maybe we have some audience from the other group.
Right. So they need to stop. Anyone should be on mute when they are not answering questions. I think they stopped. So I hope so. Okay. So for ARDS, for the COVID patient, there's some data that they may help the hypoxemia. And especially these patients need to be on droplet precaution. Having the helmet may help another protection way, so you don't get spread of the droplet infection, and they may benefit from that. But most of the ARDS patients, other than the COVID patients, they may not benefit from the non-invasive positive pressure ventilation. You may need to intubate them. Again, post-extubation, you see this large red thing. You need to extubate immediately to CPAP or BiPAP. Don't wait until, say, okay, extubate to nasal cannula. Then if they worsen several hours later, you put them on non-invasive, they will have worse mortality. So we need to extubate immediately. Who will benefit from that? Patient with COPD exacerbation and patient with pulmonary edema. They may benefit from immediate extubation to non-invasive positive pressure ventilation. Okay, sometimes we can use non-invasive positive pressure ventilation before intubation to oxygenate the patient. Instead of mask bagging them with ambu bag, you can put them on the non-invasive positive pressure ventilation to help the oxygenation. This should reduce the duration and the possibility of hypoxemia when you are trying to intubate them. Somebody is refusing intubation or refusing like DNI, they may be able to use non-invasive positive pressure ventilation. Should it use it for patient on palliative? So we decided for comfort care. This can help his breathing. If your patient feels that his breathing is better using the CPAP or BiPAP, continue it. If he feels that this is something that's bothering him and his comfort care, take it off. Neuromuscular disease, this is another indication to use non-invasive positive pressure ventilation, and everybody's familiar with the 20-30-40 rule. So 20 is 20 ml per kg for the vital capacity, and the 30 is minus 30 for the NEF, negative inspiratory force, and the 40 is plus 40 for the maximum expiratory pressure. If you have that, or if you have hypoxemia, especially at night, or CO2 is increasing, you are supposed to put them on non-invasive positive pressure ventilation. Be sure they get at least 8 ml per kg for tidal volume. If they don't have COPD, I may need even go to 10 ml per kg ideal body weight for your tidal volume. So a lot of data.
Gohar, can you repeat the 20, 30, 40 rule?
I'm sorry, can I repeat the 20, 30, 40? So the 20, 30, 40, the 20 is 20 ml per kg for the vital capacity, 20 ml per kg ideal body weight for vital capacity. So if usually you do the vital capacity frequently, and this is something that RT does bedside. And if you say your patient is, say, to make it easy example, is 50 kilos ideal body weight, if he drops below a liter, which is 20 ml per kg, ideal body weight, 20 times 50, then in this condition, you may need to put him on non-invasive positive pressure. The 30 is minus 30 for the NEF. NEF is negative inspiratory force, or sometimes we call it MEP, MIP, maximum inspiratory pressure. So this is something like clock thing, and you ask the patient to breathe out, then put this piece in his mouth, do that. And you see if he is less than minus 30, then this is a weak patient. The opposite in the same piece, he will do the opposite. He'll take a deep breath, then blow in this clock, and he should get more than 40, plus 40, what we call maximum expiratory pressure, or MEP. Make sense? Great. A lot of ALS studies that showed survival, and same thing for myasthenia. Also, data showed improvement. And to qualify your patient for neuromuscular disease for BiPAP or EVAPS or what we call trilogy, you don't need much. If his CO2 is above 45, so 45 or more. So if you get ABG and your patient is 47, he qualifies for home EVAPS if he has myasthenia or ALS. If your patient has 5 minutes overnight, less than 88%, he qualifies. So it is all. Your patient, you get the vital capacity is less than 50% of his predicted, or his NEF is less than minus 60, minus 50, minus 40, he qualifies. So even NEF minus 50, minus 60 with vital capacity less than 50% of the predicted, he will qualify for non-invasive positive pressure ventilation. Great. So for conclusion, most likely to benefit acute hypercarbic respiratory failure from COPD exacerbation or acute on chronic, acute hypoxemic or hypercarbic respiratory failure from cardiogenic pulmonary edema. If you have pneumonia, controversial, should we use it or not? If you have asthma, controversial, but I would recommend that you try for some time, see if your patient gets better. Some data that reduced admission to the hospital with asthma, those small study had 30 patients, 15 and 15 controlled study. The 15 that were placed on BiPAP, they had less admission. They were more likely to be discharged from the ED. Immunocompromised with HIV and similar medication, they may benefit from that. So you can put them on that if they have pneumonia like PCP or PGP. COVID ARDS, so we are early said we will not put COVID on non-invasive because this may spread the infection. Then later on, we found that preventing the intubation may get better outcome, and we use the high flow or the non-invasive positive pressure ventilation, CPAP or BiPAP or EVAPS to try to avoid intubation as much as we can. Any questions? Okay, so I see Dr. Baweja is here. We'll give you 3 minutes break. Then Dr. Baweja will start because Dr. Baweja has the next 2 hours and he likes more time, so we can teach you much about the acute coronary syndrome and congestive heart failure. So I will exit the share and Dr. Baweja, you can start sharing.
Hi, everyone. Do you want 2 minutes?
Yes, please.
Yes, please.
Okay, please try and keep it at 2 minutes. I got a lot to cover, so the sooner you're back, the better it is.
Again, please, if you are not talking, put yourself on mute. I will mute myself for now.
How are you doing, Ashraf?
I'm good, Dr. Baweja. Thank you very much.
Yes, sir. I thought you were on mute or didn't hear me or whatever.
No, I heard you, but I was on mute. So
yes. How are you doing, sir? Everything well?
Wonderful. Everything is wonderful. Thank you for coming for the lecture. And
whenever you have time, wanted to chat with you about a few things.
Sure.
Maybe in the later part of the week or next week.
Wonderful.
Dr. Gohar, will we be able to have access to the PowerPoint to review afterwards?
Yes, you will have the recorded course. So you will have not just PowerPoint, you'll have the PowerPoint and you will have the sound too. So you will have the video for the recording of this course once we are done. And Tani will either put it on the SharePoint, but also we can send you the connection. Zoom recording stays only for 180 days. So if you want to review it, we need to find a way to keep it longer. The chief residents are working on that, but it stays for 180 days from today. So the lecture from today, you can have it for the next 6 months.
Awesome. Thank you so much.
You're welcome.
Marie just sent out an email saying that they'll be available, the recordings, in the next 1 to 2 days.
Correct. But as I said, it will
Okay,
stay only
guys.
for 180 days.
So
Okay.
everybody's trickling in. I'm going to get started. I really do have a lot of material to cover. So again, very informal. Please stop me in between if you want to ask questions. We will try and have some time at the end too for questions. But again, these are long lectures, and by the time we get to the end, a lot of concepts have gone by. So if you feel there's a need to interrupt me in the middle for a question, please do so. I'm perfectly okay with that. I think we all learn when someone asks questions. So with that, let's get started. We're going to discuss 2 topics today. The first one is management of systolic heart failure, and the other one will be acute coronary syndrome. We'll start with the heart failure subject because I think it's a little more heavy. We'll start with some basics and get to some more fine tuning in the latter part. So do you think everybody's back, Dr. Gohar, mostly?
See 22 are on. I think
Well,
most of them are. So
most of them are back, so we can get going. Okay, great. So the objectives today for the heart failure talk, we'll talk about etiology, pathogenesis. We'll go over classification, then we'll talk about management, which will include medical and non-medical therapy. And we'll also talk about acute decompensated heart failure. So using a patient scenario to kind of guide us through our management decisions, let's pick up a Mr. X. He's a 42-year-old African-American man who came to our clinic about 5 years ago with history of uncontrolled blood pressure. As you see, the blood pressure was pretty high. We started him on an ACE inhibitor and diuretic combination pill and set him up for an appointment to follow up in clinic in 4 weeks. Now, for those of you who've been here long enough, you know what follows is not extraordinary. He did not keep his appointment. A lot of these people don't. So here was a person with significant hypertension who probably is not being treated and has been lost to follow-up. So truly enough, years later, he's back to us. This time the story has changed a little bit. He still has the uncontrolled hypertension, but now has presented with symptoms of progressive dyspnea on exertion, some orthopnea, and some PND. On exam, these are your findings. You got a little bit of tachycardia, you got JVD, you got a little lateral displacement of the apical bead. There's some edema in the legs, some rales and auscultation in the lungs. And I don't know if you guys can hear this, but this is your heart auscultation. So what do you think you guys are hearing?
I can't hear anything.
Can't hear anything? Okay, so unfortunately, I don't know how to transmit through this through Zoom. I'm going to try one more time.
I think it's difficult to hear.
Okay, I am going to let it go and keep moving. I was trying to help you hear an extra hard sound there.
I was able to hear it the first time. I think it was S3.
Okay, great. So if you were able to hear and you thought it was S3, that's great. So I think essentially what I'm trying to get to now is, what do you think we got here?
Heart failure exacerbation.
Wonderful. So heart failure is a clinical syndrome. I just need everybody to understand that it is not a diagnosis of one thing. It is a clinical syndrome. I also want everybody to understand that cardiomyopathy and heart failure are not synonymous. They're 2 different things. Cardiomyopathy is the pathophysiological problem, whereas the heart failure is a clinical syndrome that can often accompany cardiomyopathy. It is where the systemic perfusion is inadequate to meet the body's metabolic demands, and usually results from an impaired cardiac pump function, though there could be other reasons for heart failure as well. It is a huge public health problem with an incidence of over 500,000 per year, with 250,000 deaths per year, and over 1 million admissions per year. This is a big deal. Hospital office visits top 12 to 15 million, and the cost to the exchequer is nearly 5% of the entire healthcare cost of the country. So you can see why this is a big public health problem and we need to address this. So how do you clinically diagnose heart failure? Well, most of you just did. You just saw those few facts and you said this patient has heart failure. That was easy enough. But there are criteria. The Framingham Heart Study put down a set of major and minor criteria to help you diagnose heart failure. For the academically inclined, here they are. So these are the major criteria listed, and here are some of the minor criteria listed. Now, I want you to kind of appreciate that edema, dyspnea and exertion, and tachycardia, which we often associate as very vital components of trying to diagnose heart failure, are actually minor criteria. The major criteria include the S3 gallop, the hepatocellular reflux. We talked about radiographic findings, acute pulmonary edema, Ralls neck vein distension, PND. Now, if you're able to have two major criteria or one major and two minor criteria, that's a very sensitive diagnosis for heart failure. Again, the symptoms with very high specificity are orthopnea and PND. So when you find these, your specificity for diagnosing heart failure goes up significantly. The physical exam is also very evidence-based. If you think about it, the left ventricular end diastolic pressure is a good understanding of heart failure, and then the elevated LVDP is going to translate to a CVP that you can measure at bedside, and an abdominal jugular reflux added to it are all indicative of elevated LVEDP. An enlarged or laterally displaced PMI is very closely associated with a dilated cardiomyopathy that you might otherwise diagnose on an echo. An S3 gallop, again, as we discussed, is a high likelihood ratio for depressed ejection fraction. So these findings are very evidence-based and not based on just anecdotal or observation. Heart failure can come from many causes. The most common ones are listed here: coronary artery disease, hypertension, arrhythmias, and dilated cardiomyopathy from other reasons. The idea is for you to tackle the most common causes and understand how to treat them. There's many classifications for heart failure out there. The NYHA classification is a symptom-based classification that is very commonly used. The advantage of classifications is you use one term to describe a lot. So where we have class 4, who has symptoms at rest, class 1 is almost no symptoms or limitations at all, and 2 or 3 are in between. Okay, so use NYHA classification to describe your patient's clinical status. That is a very accepted method of doing that. Stages of heart failure come with more of a prognostication, whereas stage D is end-stage heart failure, stage C is present or recent past symptoms of heart failure. And stage A is kind of pre-heart failure, where you're worried about a patient developing cardiac dysfunction. I think most of you understand how heart failure comes about. Any kind of myocardial injury causes the activation of the RAS system and the sympathetic nervous system, and causes a fall in LV performance. The activation of RAS and SNS further cause peripheral vasoconstriction and hemodynamic alterations that then worsen heart failure symptoms. All of this process causes remodeling and worsening of LV function and exacerbates the problem. This entire process then adds to myocardial toxicity, and this cycle continues to ensue, where you have continued fall in LV performance, worsening heart failure symptoms, and together increased morbidity and mortality. So the idea of treatment of heart failure is always to break this cycle, and that's what we're going to talk about. Now, diagnostic evaluation, I think all of you understand basic labs you're going to need. An EKG will be helpful in understanding if there are any ischemic changes or tachyarrhythmias. BNP or NT-proBNP is become a mainstay of diagnosis, especially in the ER, and is also a good prognosticator going forward. So we'll talk about this a little bit. Chest X-ray looking for pulmonary edema, echo looking for heart function and chamber sizes, wall thickness, fluid filling status, etc. And then ischemic evaluation if clinically warranted to make sure that you don't have ischemic coronary artery disease. BNP, hardly we use this anymore because now it's more about NT-proBNP, especially with the onset of ARNIs, that is Entresto, for which BNP is a target. So hence, ARNIs cause falsely elevated levels of BNP. So if a patient is on Entresto, you do not want to follow BNP, you want to follow NT-proBNPs. So BNP more than 400 would clinch your, more or less clinch your diagnosis for heart failure. But here's your pro-BNPs. Now, pro-NT-BNPs are various cutoffs for different ages. So not as easy as a BNP cutoff where you have one universal number, but here are your cutoff age-wise. Typically, a very low BNP has a negative predictive value of 98% to rule out heart failure. It is higher in women and older age and lower in obese people. There's a lot of prognostic implications to admission levels of BNP, and especially with treatment, if BNP is not going down, then that too is a poor prognosticator for your patient. It is huge cost savings in the emergency room where a quick diagnosis of heart failure is possible. Measuring it at discharge after an acute admission for acute heart failure is a good placeholder to understand where BNP was at times of discharge. Hence, subsequent presentations and admissions can be evaluated for worsening BNP numbers. Again, there's some pitfalls for using BNP. BNP is not just an indicator of left heart failure. It could be an indicator of pulmonary hypertension and right heart failure. It'll be up in PE and atrial fibrillation as well. Whereas sepsis, renal failure, and obesity all mess with BNP measurements. So the ACC-AHA guidelines say that BNP-guided heart failure therapy can be useful in a well-organized systematic clinic where very tight regimens are monitored and measured, and then BNP can be useful in guiding therapy here. But in a regular hospitalization, usefulness of serial measurements of BNP are of little value at this time. So back to Mr. X. After doing the exam, you came to the conclusion he has CHF. You got your labs, you got a BNP that's very high, and an EF that shows, an echo that shows an EF of 10% with global hypokinesis. So you have deduced that your person has severe cardiomyopathy and is in heart failure. So the question now is, what medication will you now initiate to improve his survival? Anyone? If you said something, I didn't hear you. Try again.
I said ACE inhibitor.
ACE inhibitors. So ACE inhibitors are a good first-line agent. Here are some trials that looked at ACE inhibitors in systolic heart failure. Consensus looked at enalapril, SAVE looked at captopril, SOLVE-D, again for enalapril, and AIR for ramipril. And all of these showed significant improvement in mortality and readmission for heart failure with starting ACE inhibitors. ACE inhibitors, being excellent vasodilators, have shown improved mortality and morbidity. So even patients who are asymptomatic but have left ventricular dysfunction had reduction in heart failure admissions and mortality with initiation of ACE inhibitor therapy. And for those symptomatic patients too, the same benefits were present. Various trials showed that this difference in morbidity and mortality existed across various ACE inhibitors. So the next question was, what is a good dose for an ACE inhibitor? Any thoughts, anyone?
Starting low and going
20 to
high.
40.
So the idea here, the point of this question is that almost universally we saw that the highest tolerated dose had an incremental effect in reducing morbidity and mortality. So if you used low dose ACE inhibitor versus high dose, you had further reduction in mortality and hospitalization. So across the board, we noticed that for all stages of heart failure with reduced LV function, the ACE inhibitor with higher doses, if otherwise tolerated safely, that is renal function and potassium, et cetera, are not an issue, then they reduced mortality and hospitalization even further. And the other thing, of course, was that it didn't seem like that one ACE inhibitor was worse or better than the other. So this led us to a very good understanding that you could use any ACE inhibitor you chose. It was a class effect. The mortality benefit was a class effect. And the highest dose you could choose was better for the patient. So there was some evidence that suggested that aspirin may inhibit the benefits of ACE inhibitors in these patients, but further teasing out of data has not supported this claim. If your patient has known coronary artery disease and there's a recommendation that the patient should be on aspirin by guided therapy, then you should use aspirin and do not withhold aspirin, because there's no clear proven issues between aspirin and ACE inhibitors. What about ACE inhibitors in African Americans? Now, it was noticed that in African Americans, there's higher rates of both progressive heart failure and mortality. And the response to ACE inhibitors was not as good. They respond less well to ACE inhibitors than most antihypertensive drugs, even when used for blood pressure management. So in heart failure, we noticed that this wide difference that ACE inhibitors had on Caucasian population in reducing hospitalization was much narrower in African American populations. And we also noticed that as an antihypertensive drug, ACE inhibitors were pretty close to placebo in African Americans, whereas other drugs such as calcium channel blockers and diuretics were much more effective antihypertensives in African Americans. But despite that, what we figured was that the relative risk reduction of death was reduced the same amount in both populations. So the indication to use ACE inhibitors for heart failure is across the board and is not race dependent, okay? But what about beta blockers in systolic heart failure? You guys universally said ACE inhibitors as a starting drug, but what about beta blockers? Now, I would like you to know that beta blockers have tremendous evidence in reducing morbidity and mortality in heart failure, but like ACE inhibitors, which are now a class effect, which means you can use any drug, beta blockers are not. Only these beta blockers have been shown to have morbidity and mortality benefit in patients with heart failure. And these are long-acting metoprolol, not the tartrate, but the succinate version, carvedilol, and bisoprolol. So if you are going to use a beta blocker, it's got to be one of these three and not any other. Here are the trials that supported this, this clear evidence of benefit. The CIBIS, MERIT, and Copernicus trials showed tremendous advantage in mortality and morbidity improvement in patients with heart failure. So no, all beta blockers are not equal. Various trials showed that other drugs, other beta blockers used, such as bosindolol in this study, didn't have any improvement in survival. Zimeterol in another study actually showed that mortality was worse with Zimeterol than placebo. So not all beta blockers are equal. Please remember that. Some can actually be worse. What about optimal dosing for beta blockers? Now, we talked about ACE inhibitors and said the higher the dose, the better. If you can maximize therapy on ACE inhibitors, they do better. But what about beta blockers? Any thoughts, anyone?
Same thing.
Same thing. Well, kind of, yes. These are the maximum doses and these are the target doses that we are trying to achieve. It was very clear in non-ischemic cardiomyopathy that serial increase in doses actually help patients improve their EF more and hence reduce morbidity and mortality. In ischemic cardiomyopathy, that definition was not so clear. But for simplification and the fact that in ischemic cardiomyopathy, you are trying to achieve lower heart rates to reduce oxygen consumption of the myocardium. So the increased doses of beta blocker are beneficial in different ways. Hence, the recommendation is to have the highest possible dose of beta blocker, whether you're treating ischemic or non-ischemic cardiomyopathy. So now that we've talked about two excellent drugs and both of them seem to have very beneficial effects in these patients, what if you had a choice? Which drug would you start first? Any thoughts?
We'll start both, but if I have to choose one, I will start with the beta blocker.
So if you had to start one, you said you'd start with a beta blocker. Any variations? Anybody thinks otherwise?
I start with the ACE
Based
inhibitor.
on the,
So I think we have seem to have a favorite drug. Many people think an ACE inhibitor is better. Others think they would start a beta blocker first. I think what all of us realize is that if it's acutely decompensated heart failure with possible hemodynamic compromise, and you're starting a brand new drug that's not on there before, then you do not want to use beta blockers, because beta blockers will worsen the heart failure because of their negative inotropic effect. But on the other hand, if we move the decompensated patients aside, then the question's still there whether beta blockers or ACE inhibitors are better. But in decompensated patients, use ACE inhibitors first. They have a lot of benefit in reducing the neurohormonal activation that is persistent in these patients, and also improve peripheral vascular resistance by causing vasodilation, which the heart really needs. So ACE inhibitors should be your first choice of drug in decompensated patients. But in compensated patients, it's perfectly okay to use beta blockers first. So neither is the wrong answer. It's just a condition of which patient you're using. If we look at the CIBIS-3 trial, very elegantly designed trial of about 1,000 patients that looked at all these patients with heart failure and reduced ejection fraction. And what they did was they randomized them to monotherapy with either a beta blocker or ACE inhibitor first. And they carried on this for a period of, I want to say 6 months. Yeah, 6 months. And then crossed over to an arm where both medicines were continued thereafter for 6 to 24-month period. And the idea was to see if there was any difference in morbidity, mortality, hospital readmission, etc. So it actually was completely the same. So whether you started a beta blocker first or an ACE inhibitor first, and then you put them on both drugs, they did the same in terms of hospitalization and death. So you would not be wrong in a compensated patient to start a beta blocker first. In a decompensated patient, you're looking at ACE inhibitors first. Clearly, your patient has fluid overload, the Mr. X we were talking about, right? So you start an ACE inhibitor, but now you're trying to think of, how to get his fluid off so he can feel better. So you need a diuretic. The question is, what do you do? Do you start him on a low dose of diuretic, high dose, bolus, or continuous infusion? How do you choose what diuretic you want for your patient? Well, the answers to these questions came from the DOSE trial that looked at acute heart failure patients with less than 24 hours after admission, and they randomized their patients to either a low dose IV bolus, a low dose continuous infusion, a high dose continuous infusion, and high dose IV boluses Q12 hours to see which of these groups did better. What is a better strategy for diuresing these people? And what they looked for was to see how the patients did in terms of feeling better, breathing better, being discharged first, and looked at objective parameters such as kidney function, potassium replacement, this and that. So here is a score of looking at how the patient felt. Did they feel much better between Q12 versus continuous infusions? And you can appreciate that this is pretty much not much different. So whether you bolus people or you put them in a drip, they didn't seem to do much differently. Then the idea of whether you put them on low dose, 20 BID versus an 80 BID kind of schedule, and there was a difference here, approaching significance, but not quite. And this was that, of course, with high intensity diuretic, you diuresed more, you felt better a little sooner, but it came at the cost of renal derangements, right? So creatinine, of course, no doubt that if you used high intensity diuretics, your creatinine bumped up much more.
Please, thank you.
Okay,
Have a
was
good
that
day.
somebody asking me a question? Oh no. Is it a mute condition again? Please don't do that to me. I saw Dr. Gohar struggle with that. That was not fun. Anyway, so the idea is that no matter what kind of therapy we used, trying to assess quality of dyspnea and how they felt, and looking at weight change and looking at creatinine change, there was some approaching to significance when you used high dose diuretics, but it came at the cost of kidney issues, right? So what really is the answer? The answer from this trial was there's no statistically significant difference no matter what strategy you used. But this trial had a deficiency. It did not include patients who are at significant fluid overload and severe heart failure. They chose patients with milder heart failure without hypotension, without requiring inotropes or vasodilators. So, you know, I think the results of this study are interesting because it means that there's not a big difference no matter which therapy you choose. But then there are some special cases that you should try and assess. So if your patient has hemodynamic issues or kidney issues, I find that they do better, and these are again expert opinion as well, that they do better with infusions rather than boluses of diuretics. So think of infusions in patients who have hypotension, borderline blood pressures, or underlying AKI or CKD combination. Cat D, whoever you are, please mute yourself. Cat D, are you there? Can you please mute yourself? Good Lord.
We don't know who is there, so that's the problem.
Yeah.
I think even she doesn't know that she's logged in. She's talking about prostate cancer.
I think she's mute now. We're good. Thank you. So, in the patients that were in the trial, there was no difference. So we can use whatever strategy suits your fancy. Okay. So here, back to your patient. We did adequate diuresis, retained some eubulimia. You have now a very good medical regimen going for him with ACE inhibitors, beta blockers, diuretics, and you then follow up in 2 weeks in your clinic and the patient says, I have a persistent cough. What do you do next now that your patient is complaining of cough?
Stop lisinopril.
I kind of almost give you the answer there. Yeah. So would you replace the ACE with an ARB? The answer is yes, right? So ACE inhibitors will fairly commonly have a milder side effect of dry cough. Replacing with an ARB should get rid of that problem. Now, ARBs are good in heart failure, as good as ACE, and that data came from the CHARM alternative trial, which compared patients on ACE inhibitors and then compared with patients on placebo and then on candesartan, and then saw that CV death and hospitalization reduction with candesartan was fairly approachably equivalent to ACE inhibitors. So this gave us the confidence to use ARBs instead of ACE inhibitors when that was not tolerated. So here's your patient back again on those medications, and you follow him in clinic every 2 weeks in his meds, and after 2 months he's on much better doses. You finally have maxed out the beta blocker and the ACE inhibitor, so you're on hopefully optimal doses of these, but he continues to be in bad heart failure. NYHA3, if you remember, is shortness of breath with minimal activity. So now you're in NYHA3 still, despite this very good medical regimen. So what do you do next?
Can add spironolactone, 25.
So I heard a few things. So you have some options, yes. So do you use either you use aldactone, like some people said, or do you add hydralazine isosorbide, commercially known as Bidil, or do you add ARB on top of ACE? These are some of the options, and I think some of you said those options. So the trial to discuss here is the AHEFT trial. It was a VA trial that looked at mainly African-American patients, and the idea was to add more vasodilators different from ACE inhibitors or ARBs, a combination of hydralazine and isosorbide dinitrate to your heart failure regimen and see what that does. And they saw a significant reduction in mortality in these patients. So initially, the trial composed mostly of African-American patients. Then they did more subgroup analyses looking at Caucasian population as well, and found that there was a reasonable reduction in mortality even on the Caucasian population, though not as robust as what we saw for African-American population. So the subsequent guideline recommendation of using Bidil or this combination of drugs was for across the board for both groups and not limited to African-American population. So there was a very significant reduction in mortality by using these drugs on top of maximized ACE and beta blocker. So in addition to beta blockers and ACE for African-American population with a persistent heart failure, and it may be considered in non-African-American patients too who remain symptomatic despite optimization of beta blockers and ACE inhibitors. And it may be considered in patients who are intolerant to ACE. So many times we'll have people who just can't tolerate an ACE and an ARB because either they have severe allergic reactions such as angioedema or have bad kidney functions, hyperkalemia issues. Then this would be an alternative therapy for those patients regardless of race. Okay. Then some of you mentioned aldactone. The data for that came from the RALS study that looked at spironolactone that shows a significant reduction in mortality as well in these patients. And aldactone comes with many benefits, not only the mortality benefit purported here, but also the fact that it is a diuretic and also the fact that you don't have to worry about potassium as much in these patients. So using aldactone as a next line agent is a key progression to therapy for your heart failure patients. Many patients with aldactone will compare, especially male patients will compare of the endocrine side effects, which cause gynecomastia. And then you do have an option with eplerenone, which by the Emphasis Heart Failure trial also showed similar benefit in reduction of death and hospitalization without the endocrine side effects that aldactone carried. So if any of your patients have problems with taking aldactone, you can offer them eplerenone. The only problem is it is much more costly. So now, in more recent guidelines in 2013 and 17, they even broadened the use of aldosterone antagonists to class 2 heart failure patients. So just know that. And they also broadened it to heart failure with preserved EF patients. So your indications to use aldactone is now much wider, and pretty much anybody with heart failure would be a candidate. Again, eplerenone, lesser endocrine effects, better tolerated, but higher cost. So that might be your consideration as you decide to use that drug. But what
Doctor,
about?
I have a question. I'm sorry.
Yes, sir. Please.
So which one first, the MRA or the hydrolazine isorbate? If I have to choose.
So very good question. So I think if it's an African-American patient, I would choose the Bidil first. And if not, then I would choose the aldosterone antagonist first. And the guidelines kind of suggest the same.
My second question is spironolactone at the doses used in heart failure, do they induce diuresis?
Absolutely. It may not be as potent a diuretic as an on-top furosemide or torsemide that you may use, and hence it's seldom the only diuretic used.
Thank you.
Okay. So what about data for ACE and ARBs together? Anybody thinks that's a good idea? Put ACE and ARB together at the same time?
No.
I think everybody thinks no. So as we looked at the sorry, somebody said something? As we look at the VALHEV study that looked at a person on ACE inhibitor and then either a placebo or an ACE inhibitor in valsartan, we saw that there was not a real mortality benefit from putting an ACE on top of ARB. But what we did see was their kidney function, their potassium, all did worse. So in essence, no more morbidity or mortality benefit from a heart failure perspective, but higher complications. So what they noticed was that whenever you had ACE inhibitor present, your patients did worse. If you did an ACE inhibitor absent with beta blocker added, your patients did better. Okay, so whether you looked at heart failure admissions or death, the idea was to not use both ACE and ARB together. That was seldom useful. So our current guideline status on this is ARBs are recommended for ACE intolerant patients. ARBs are a good alternative to ACE for some reason if a person doesn't want to take ACE. But addition of ARB to ACE, it says you can have a class 2B indication if aldactone is not indicated. But if you realize 2B is very gray. I mean, 2B, I seldom find people doing 2B things. So even though it exists as a possibility doing 2B, it's not really a strong evidence. But the routine use of ACEs and ARBs is definitely a class 3. It's harm, don't do it. So finally, here's your patient. You then did Bidil, beta blockers, ACE inhibitors, Lasix, everything's going well. You scheduled to see him in clinic for an EKG and echo in 3 months. And when he returns to clinic, his EF is improved from 10 to 20, but he does report still shortness of breath with activities of daily living. So that's almost still a class 3. So you've done all these good things and your patient's still not feeling the best, right? So now what is your next option? So if you look at the 2016 guidelines, we now have a newer option. I don't call it new anymore because it's been around a bit already. And that is ARNIs, or neprilysin inhibitors, in combination with angiotensin receptor blockers. So ARB and neprilysin inhibitors together. And your trade name is Entresto. I think a lot of you have used this. So the data for using Entresto came from the Paradigm heart failure study. And it is a combination of an ARB and a neprilysin inhibitor. Okay, so it's a fixed dose combination. There's a starting dose of this combination figure. That's what you would use. Unless your patient is currently tolerating a full dose of ACE or ARB, then you can start at the higher dose right away. Okay. Typically, if your patient is on an ACE and ARB, you stop that 36 hours before starting therapy, and then start the Entresto subsequently based on the dose of the ACE that was ongoing. Your target dose, that is highest dose, is this twice daily. So you titrate 2 to 4 weekly to the next dose, monitoring blood pressure, renal function, and potassium. If there's history of angioedema to ACE or ARB, you cannot use this drug. You cannot use this drug with concomitant use of ACE inhibitors or aliskiren. If your patient is not on an ACE and ARB and is a heart failure patient that you have on a beta blocker and now you're thinking, I want to start an ACE, it is perfectly reasonable to skip starting the ACE or ARB and just go to ARNI. Okay? So just letting you know that you no longer have to think of starting ACE and ARB, then switching over to ARNI. You could straight away go to ARNI if it's a de novo start for you.
Question.
So, yes.
For the washout period, 36 hours, do we need that only for the ACE inhibitor or the ACE and ARB?
You know, typically just do it for both, because even if you're on the ARB and then you're going to dose another ARB at the same time, and that's not a good idea. So wait out 36 hours whether you're on the ACE or on the ARB. So the Paradigm heart failure showed that in comparison to just ACE inhibitors or ARBs alone, there was a further absolute risk reduction of CV death of 10.9% by replacing it with ARNIs. So significant risk reduction for heart failure patients with making this change. So just very simply, what do ARNIs do? So with heart failure, there's a lot of endogenous vasoactive peptides, the natriuretic peptide, the substance P, calcitonin gene-related peptide, all these endogenous peptides released by the body that are actually beneficial. They reduce neurohormonal activation, reduce vascular tone, hence reduce peripheral vascular resistance, reduce cardiac fibrosis, and reduce sodium retention. These are all beneficial components. But the enzyme neprilysin converts all these to an active metabolite. So if you use a drug that inhibits the neprilysin, then you have more endogenous peptides that help the body and hence tackle heart failure more effectively. And that's the basis of a neprilysin inhibitor. And again, the big deal here is the very short and small number needed to treat to save a life of 21. So CV death and heart failure hospitalizations both reduced significantly. So back to your patient. So now Mr. X is on Entresto, and you have everything else going. You have Bidil, Coreg, Aldactone, Lasix, and now you see the patient and his EF has improved a little further, and he still has shortness of air and activities of daily living. So I'm trying to just lead you through the progression of treatment here. So he says, I read something in the news about new therapies of heart failure. Doc, have you been following the news? What's going on? So what do you want to do next? Any thoughts?
SGLT2.
So SGLT2. So this is the 2021 ACC update to heart failure management that covered a few topics, and of them is SGLT2, and I'm going to talk about that. But the 2021 update really talks about a few more things that you really need to work on understanding your heart failure patients, what are their barriers to appropriate medical therapy, and improve their compliance by looking at their socioeconomic conditions, their understanding of drugs, and other psychological and social barriers that may exist in them not taking their medicines. So improving compliance, trying to understand their affordability and understanding of the patient is now a key responsibility of the physician and even recommended in the guidelines. Okay. Also, 2021 guidelines talked about the benefit for right heart caths. So if you have a patient who's not diuresing as well as you would hope, kidney function is going bad, you think you got cardiorenal, right heart cath can help you delineate filling pressures and estimate if you need further diuresis. Are you in poor forward flow because of fluid overload, or are you in poor forward flow because of volume depletion? So RHC right heart cath can answer that question very quickly. The other option is now an implantable device called CardioMEMS. It's a tiny little, it's really about yay big, tiny little thing that you can implant into the pulmonary arterial system. And it is a continuous pulmonary artery pressure monitor that'll wirelessly monitor pulmonary artery pressure from the outside. The patient has a little pillow that they put their head on, and it'll tell them their pulmonary pressure and transmit it to their doc. So CardioMEMS has been shown to effectively tackle heart failure before things get worse and reduce hospital presentations and admissions. So somebody who has got labile heart failure and you're constantly struggling with keeping on top of diuresis, CardioMEMS is a good option for patients like this. Another thing, as people develop dilated cardiomyopathy, they have dilation of the mitral ring, which causes poor coaptation of the mitral valve and causes severe mitral regurgitation. Now, severe MR then makes things worse. There's a lot of now backward flow into the left atrium, back into the pulmonary vasculature, increases the pulmonary blood pressure, pulmonary arterial hypertension and flow, and just makes things worse. Their symptoms are worse, and there's bad MR, and there's more fluid to deal with, and the heart's constantly under more fluid overload now, and things just continue to get worse. So now there is an indication of treating functional MR with transcatheter treatments, not a surgical replacement, but a transcatheter treatment such as a mitral clip. If you've heard of a mitral clip, it's a little clip that you can put on the mitral valve and reduces the orifice area of the valve and improves the competency of the valve and reduces the amount of mitral regurg. So now an indication for patients who, after medical therapy, are still symptomatic with bad functional MR to consider transcatheter treatments for that functional MR. And then the other thing that this latest update on the guidelines focuses on is specialist referral. So I found this very neat mnemonic that they put up there that said, I need help. Okay, this is in the guidelines, mind you. And it said that if you have any of the I need help characteristics, it's time to engage advanced heart failure specialist. Call the cardiology team. So if you have IV inotropes, bad heart failure with persistent BNPs, end organ dysfunction such as kidney function or positive tropes, ejection fraction that's really low with this history of defibrillator shocks, multiple hospitalizations, edema, despite escalating diuretics, and blood pressure that continues to be borderline, or prognostic medication intolerance or down titration of guideline-dependent medical therapy, then those are all reasons why you should think of involving a cardiologist. Okay, so just remember what you should think of when calling for help are these components. Okay, now back to the original question: what is the next line of therapy? So in 2020, FDA approved a new drug for heart failure management, and rightfully, as you said, these are SGLT2s. Okay, so SGLT2 inhibitors, found great use in heart failure and diabetes, and they found that it worked for both because there were many similar pathophysiological features. The endothelial dysfunction, the insulin resistance that both diabetes had, as well as heart failure had, benefited from use of SGLT2 inhibitors. The mechanistic effect of SGLT2s was seen in patients with and without diabetes, which means that if you use them on pure heart failure patients without diabetes, they too had the diuretic effect due to natriuresis and glycosuria, and the metabolic effect of increased glucagon, increased ketone bodies. So the benefits of these inhibitors existed independent of glucose levels and could be used in heart failure patients without diabetes as well. So how do SGLT2 inhibitors work? A very simplistic diagram trying to show you in the kidneys the reuptake of glucose in the nephrons. There's an SGLT2 segment and an SGLT1 segment. So when the SGLT2 segment is responsible for most of the glucose reabsorption, so when we use SGLT2 inhibitors, we are not going to absorb that glucose. All that glucose is going to remain to be ejected, and hence goes with it a lot of fluid, right? So that's diuresis in terms of glycosuria, and the benefits of heart failure that come from this are Of course, with fluid loss, you have decreased pre and afterload. But in overall, all of this improves cardiac metabolism and decreases cardiac fibrosis and decreases inflammation in epicardial adipose tissue by decreasing sugars and causing more glycosuria and diuresis. So there's a lot of beneficial ways in which SGLT2 inhibitors are good for heart failure patients. Multiple trials have now looked at these, and here are the data from some of them. Reduction in CV death and heart failure hospitalization for these drugs across the board. So quickly, here's the overview. Who gets to be on these drugs? Patients with reduced EF for now who have heart failure are hemodynamically stable, and it doesn't matter what stage of guideline-directed medical therapy they're on. You can start SGLT2 inhibitors at any point, and it does not matter whether they have type 2 diabetes or not, okay? What you should not use SGLT2 inhibitors are if, one, your patient has type 1 diabetes, two, if there's impaired renal function, and creatinine clearances are listed in the pharmacopoeia if you're interested. And if the patient is going to be on an SGLT2 inhibitor, think of a diuretic reduction, because the diuretic potential of these drugs is immense. If you leave the diuretic that the patient was on at initial doses, you might cause prerenal AKI for your patients. So when you start these, think of diuretic reduction. But the bottom line is there's a significant reduction in all-cause death, CV death, and heart failure hospitalization with SGLT2 inhibitors in heart failure with reduced EF. So strongly recommend this next class of drugs for your consideration when you are getting to this point. So now with all this data, you're armed to use SGLT2Is, and you started your patient on the same and then said, okay, we'll follow up again. His EF didn't get better and he comes back still short of air. Now what do you do?
ICD, CRT.
Excellent thought. So here is an EKG of your patient. As you look at this EKG, what do you see?
Left bundle branch block.
Left bundle branch block. So the idea here is twofold. One is to see that you have a wide QRS, which means that you have a bundle branch block, especially a left bundle branch block here, and your two ventricles are not in synchrony. So think of the two ventricles not being in synchrony like two pistons that are not timed well in a car engine. Okay, if the timing is not well, then energy is being lost in trying to translate that engine into motion. So if the two pistons are not in sync, that's what your timing belt in your car does. If you ever have to get a timing belt replaced, you know how much it costs and how critical that piece of equipment is. So if your timing belt went bad in the car, your car wasn't performing well. Now, in the heart, you got the same problem. If your timing of your two chambers isn't in sync, you're wasting energy, because when one ventricle contracts, the other one is not quite ready to process that part of the cycle. So retiming the heart is what is CRT, right? Cardiac resynchronization therapy. And then, of course, the ICD component, the defibrillator component. So both of these have immense benefit in heart failure patients. So let's talk about one at a time. Sudden cardiac death. Heart failure patients experience sudden cardiac death almost 8 to 9 times the rate of the general population, and is the predominant mode of death in class 2 and 3 heart failure patients. So in class 2 and 3 heart failure patients, predominant mode of death is sudden cardiac death. Okay, in class 4, it's heart failure, but in 2 and 3, it's sudden cardiac death. So clearly, a defibrillator is beneficial. So the SCOTF trial looked at putting patients at risk on either amiodarone or ICDs, and found very quickly that ICD therapy was giving tremendous mortality benefit. Amiodarone and placebo were not much different. So no role to amiodarone on these patients, but ICD therapy was here to stay. And even if you have you should have at least a 1-year survival. You're going to put an expensive device. You don't want to put in someone who's about to go away. So at least a 1-year survival in class 2 to 3 heart failure, and even in ischemic cardiomyopathy with reduced EF, this is a very good idea. And then we talked about dysynchrony, where the two ventricles aren't in sync anymore. So resynchronizing them by pacing both the left and the right ventricles together is your cardiac resynchronization therapy. The device is built into kind of one package, the ICD and CRT. So most patients with wide QRS and left bundle can, instead of just an ICD, get an ICD CRT. So what does CRT do? It improves cardiac function. It decreases cardiac oxygen consumption and decreases the chance of arrhythmias. It improves LVEF, improves quality of life, improves heart failure classification, and there's a mortality benefit too. So truly, cardiac resynchronization, though an expensive therapy, is very beneficial for the right patient group. Again, more data trying to show you with multiple trials how CRT is beneficial. Meta-analysis showing you whether you look at heart failure hospitalization or all-cause mortality, CRT is a good idea. So there are current indications, EF of less than 35, NYHA class 2 to 3, and cardiac dyssynchrony in the presence of a left bundle with QRS more than 120. Okay. So you did all that. Now you got your patient a CRT, and you've all those medicines that we've been talking about. You've been doing all those good jobs, and now your patient is really happy. You did good for him. He feels like you've been trying to take care of him. But what if he said, I still don't feel better? What can you do next?
LVAD heart transplant.
LVAD heart transplant. Well, there's a few things you can do before you get there. So let's not forget the age-old drug digoxin. So digoxin didn't have any mortality benefit in these patients, but did have a benefit in reducing representation to the hospital for heart failure. So it's a very valid drug to have for someone who keeps coming back with heart failure to the hospital, though understand that it has no mortality benefit. So levels of less than 1 are associated with less mortality, but if you get to levels more than 1.5, then you're getting to dig-toxic levels. So we try to target doses, dig levels between 0.6 and 1.3. But let's say you did your dig and now your patient still says, oh, I still don't feel good. Now what?
You had ivabradine, maybe?
So ivabradine, absolutely. So ivabradine, so if your heart rate is greater than 70 despite maximizing beta blockers, that's clearly not helping the patient's heart failure by not optimal filling times, increasing oxygen demand. So there's now a drug that you can use to reduce heart rate in patients who are still going past 70 beats a minute despite maximal beta blockade. Okay, so that's ivabradine, and clearly has shown reduction in CV hospitalization for heart failure. Okay, so reduction in heart failure hospitalization. So here's kind of highlight of what we've discussed till now. I just wanted to show you that all of these interventions that you did, what is the relative risk reduction? What is their NNT, number needed to treat? So you see the lowest NNTs, Bidil, aldosterone antagonists, low NNTs here. Just trying to show you how effective these therapies are in comparison. I found this to be a very interesting table. But know that there are two drugs that only reduce hospitalization and do not reduce mortality, and these are digoxin and ivabradine. Everything else that you so far discussed reduces both hospitalization and mortality. Okay, these are the only two drugs that don't reduce mortality.
Dr. Baweja, I have a question.
Yes, sir.
So in ivabradine, is it started on top of beta blocker or
yes,
just
absolutely on top of beta blocker, and you can start at a dose of 2.5 or 5 based on age, and then titrate up. I think the maximum dose is 10.
Okay.
One more question, Dr. Baweja.
Yes, sir.
I always hear this thing about if the patient is Lasix naive, you shouldn't give too much Lasix in regards to your discussion of low versus high dose. How does that fit in?
So, again, I agree with you that if they're Lasix naive and have preserved renal function, they may be very responsive to lower doses of Lasix, and I would start there. But if kidney function is compromised or, you've noticed escalating doses of Lasix, you don't have a choice. But I agree with you, starting low dose is fine on patients who are naive and preserve kidney function. Okay, I want to continue and talk a little bit about acutely decompensated heart failure, where you have some more management options. So here we're going to talk about ultrafiltration. We're going to talk about vasodilators in the form of nitroprusside or nitrates. We're going to talk about other diuretics other than Lasix, and we're going to talk about inotropes with dobutamine, dopamine, and milrinone. And we're going to talk about airway support using CPAPs and BiPAPs. Okay. So a little more complex here, so please try and stick with me. This is really board-rich material, what we're going to discuss now. So if any of you is going to be worried about boards, this stuff is going to be really useful, so stick with me. So let's talk about these groups of patients with heart failure, okay? The first one here is where there's an increased preload but a normal cardiac output. The second group here is someone with valve regurgitation, diastolic dysfunction. This person has an abnormal EDP with possibly a depressed cardiac output. And then the third group has severe systolic dysfunction and high afterload with a severely reduced cardiac output. So we're looking at three groups here and trying to see how you're going to treat these people, okay? So when you think of this first group, you think mainly diuretics. When you think of the second group, you think diuretics with possibly vasodilators. As we go to this third group, you definitely need diuretics and vasodilators, but you also need inotropes. So look at the pressure volume loops here and follow with me, okay? This is a graph showing left ventricular end diastolic pressure with left ventricular end diastolic volume. In a normal patient, as you increase the volume, which is you increase the preload, you increase the left ventricular end diastolic pressure. Common sense, right? Everybody gets that? But in dilated cardiomyopathy, this is offset differently because the response is entirely different from a volume to pressure ratio. You need more volume to cause that problem because your heart's more dilated, and the linearity of this curve is much sharper, where towards the end, the EDP drastically goes up, okay? Keep following with me. This is all going to tie in a second. In diastolic heart failure, the curve actually shifts a little more up and left. It becomes way more steep, where lesser changes in volume cause more changes in EDP. Now, this is a very key concept to understand. In dilated cardiomyopathy, you add more fluid, you raise the pressure, and it is a curve that takes a long time to get to the sharp component. In diastolic heart failure, because the heart cannot stretch, small changes in volume cause big changes in pressure. Hence, the converse is also true. In diastolic heart failure, once you diurese them, if you go past, smaller changes in reduction in volume really drop the EDP. Now, why is this important? Because EDP is closely related to cardiac output, and this is your Frank-Starling curve. So with increasing EDP, you're going to have increasing cardiac output until the time you reach the stretch limit of the heart, and then further increases in EDP will not improve the cardiac output. But now think of it in dilated cardiomyopathy. As you increase the EDP, to some extent, the cardiac output goes up. But here is your optimal point. You add more fluid, raise the EDP more, and your cardiac output starts to drop. This is your clinical presentation of heart failure. So what you need to do is you need to reduce EDP to get to this point where cardiac output is at its best. How do you reduce EDP? Going back, you reduced EDP by reducing the volume. So you want to diurese these patients. So your EDP goes down and your cardiac output goes up. Okay. This is really important you understand this, because they will give you a point here and a point here and say, what drug caused this change from here to here? Okay, this is very common board questions. So just follow along, okay? Now, look at diastolic heart failure. As I was trying to tell you, the reduction in EDP beyond a certain point is going to cause drastic fall in cardiac output. So diastolic heart failure patients are harder to maintain because they have a very narrow therapeutic window of fluid balance. A little extra fluid and you push them into heart failure. A little too less fluid, and you push them into a fluid depleted state where their cardiac output falls and they will go into cardiac volume depleted failure, shock. Okay, so know that these curves have very different characteristics. I'm going to come back to some more volume curves in a second, okay? But in the meanwhile, let's just look at the subsets of heart failure that you're used to looking at. They are based on whether you have low output or you have congestion or both. So if you have low output and you have congestion, then you're looking at a cold and wet patient because you have high wedge pressures with low cardiac output and index. If you don't have either, you're looking at normal wedge and normal index. But if you have just low output but no congestion, you're looking at a low index with low wedge. But the warm and wet patients are the ones you want to understand in addition, are where you have a good index but a significantly elevated wedge. And based on these, you're going to alter your treatment, right? So back to this, let's look at the patients who are congested, okay? Whether it is with a depressed output or not, these are patients who are fluid overloaded, okay? So back to our hemodynamic curves. So this is how diuretics are going to work, right? We were just talking about it a second ago. In dilated cardiomyopathy, you give a diuretic, you'll move your patient from here down to here. Your LV EDV went down, your LV EDP went down too, but on this curve, you went from here to here and your cardiac output improved. This is what diuretics did for your dilated cardiomyopathy patients, okay? So this is what you're trying to achieve. Very common board questions. I promise you, you're going to get them. Will be these curves with some marks on them and say, what drug did this patient get? Choose one out of the 4. Or what drug would you want to give the patient to go from point A to point B? And they'll give you one of 4 to choose from. Okay. So now back to some clinical management, loop diuretic strategies. One thing that we all need to understand now is the bioavailability of oral Lasix is poor in patients with gut edema and decompensated heart failure. We discharge all these patients on PO Lasix at home, and it is a rather ineffective drug if they have persistent gut edema. In the hospital, you're giving them IV boluses and infusions, and they're doing well because the bioavailability of IV medications is high. But the moment you switch them to oral and send them home, things don't last well. They keep coming back. And then you have these readmissions, and you're wondering what the hell you're doing wrong. And you cuss the patient, you're thinking they're not doing their job right. They're drinking too much fluid and not taking their meds. But it ain't that. It's just that we're giving them a medicine with poor bioavailability given orally. So if you continue to have patients who come back with oral Lasix, think of torsemide or bumetanide, okay? The bioavailability is so much different. Look at the range of bioavailability for Lasix versus these drugs, okay? So think using torsemide or bumetanide, and these are now available at Truman regularly in the pharmacy, and you can use these drugs and get much better results on your outpatients, okay? You all need to know the conversions. I'm sure you'll figure this out. And then, of course, know the dosing regimens because they have different duration of actions. But my idea was to introduce to you to use torsemide as an oral outpatient drug instead of Lasix in these patients with heart failure and poor bioabsorption. No, and here's your question, Ruben, you were asking that in patients with established heart failure, you know, to get the same FeNA, you're going to need higher diuretic concentrations. And this is where you start to think of these patients with heart failure requiring higher and higher doses of Lasix. And one way you can overcome is by using drugs with better bioavailability. So if your patient starts to get refractory to volume overload, start thinking of adding a thiazide diuretic to potentiate the loop diuretic. Think of adding metolazone or chlorothiazide, okay? And then when all else is failing, remember ultrafiltration is an option for your inpatient. It may give the patient a diuretic holiday, desensitize the kidneys to that, all that Lasix you've been throwing, and it's greater sodium removal. And you can use these in patients with marked fluid overload and poor response to diuretics. The unload trial looked at using ultrafiltration and showed excellent results. Okay.
Baweja, how important is it to give the metolazone or chlorothiazide 1 to 2 hours before you give the Lasix?
Oh, absolutely. I think you gotta at least give it half an hour plus before the Lasix because that's the potentiation of the nephrons. If you don't time it right, it ain't gonna work. So at least 30 minutes prior to your loop diuretic. So just trying to show you the ultrafiltration setup. Again, that's not the main purpose of my lecture today. And for sake of time, let's go back to the more important high yield stuff. Okay, we talked about diuretics, but now what about vasodilators? Let's look at these curves again and look at vasodilators, okay? Now here we are. If you use a vasodilator, right, what you're gonna do is you're gonna drop your systemic venous resistance, right? So in a SVR to EF, because your SVR goes down, there is less forward resistance. Your EF is going to improve in dilated cardiomyopathy. So here is your rationale for using vasodilators in patients with dilated cardiomyopathy. As your SVR goes down, your LV-EDP will go down and your cardiac output will improve too. Okay. So let's say somebody draws this diagram and diuretics is not one of the options. They're saying, what will cause you to get here? Lisinopril, beta blockers, calcium channel blockers, or clonidine. You know what answer you're going to pick, right? Okay, so everybody's kind of getting this, the volume loops? Okay, hopefully you are. If not, available for questions later, okay? Now, vasodilator therapy in heart failure is proven. Continuous chronic vasodilators in oral forms have plenty of data. But intravenous agents are used in patients who are acutely ill and in the hospital, so the data is little scant, okay? But there's good anecdotal data now that we have from so much of experience that these are helpful in getting your patient better. You're not going to have trials on these patients, so there's not a lot of trial data. So IV nitroprusside is an IV vasodilator you can use in patients admitted with heart failure, decompensated heart failure in the ICU. It's a potent vasodilator. Remember, because of its hemodynamic potential, you need intensive monitoring, possibly a PA catheter and an arterial line, and be worried about thiocyanate toxicity. So you can't use it for more than a couple of days, okay? And IV nitroglycerine, again, it's much easier and safer than nitroprusside, but you develop tachyphylaxis to nitroglycerine very quickly. So there too, the benefit is lost in a few days and you can't continue to keep using it. But these are potent IV vasodilators that you can plan to use. Again, you're not going to find a lot of trial data to support these, but these have clear experience data, and that's why they use. Okay, getting down to our low output patients, we talk about our congested patients, but now the low output patients, back to the volume loops. So look here, what is your inotrope going to do? In the low output patients, you're thinking inotropes. So what is your inotrope going to do? It's going to create a new curve. It's going to raise for the same SVR to EF ratio, it's going to give you a higher curve. For the same LV-EDP to cardiac output ratio, it's going to give you a higher curve. It's going to translate the whole curve up. Okay, and this is what inotropes will do in your patients with severely reduced output or index. Again, the evidence for inotropes isn't going to be big because these are patients in cardiogenic shock. You hardly ever get to do trials on these patients, but there are smaller studies and observational data. The Optime heart failure study showed the benefit of using milrinone in these patients. Okay, so the data, again, from the study may not have been as convincing as we would like, but realize that, again, when you're trying to do trials, you're not going to do them on your shocky patients. You're doing on patients that are a little more stable, and that's where these drugs don't have the benefit. So the patients to use these drugs are on your unstable, sick patients, and there's little evidence of inotropes improving heart clinical outcome in stable patients. Do not use them in stable patients, okay? Using balloon pumps in really sick patients has some data too. Again, balloon pumps, as you know, inflate in diastole, deflate in systole. So the moment systole sets in, the balloon deflates and reduces afterload, and the moment diastole sets in, it inflates and then improves cardiac coronary supply by improving the volume in diastole. So intra-aortic balloon pumps find some value in improved oxygenation to the heart and reducing afterload in systole, and can be used in patients with heart failure, end-stage heart failure as well. But of course, the vascular complications, infections, and bed rest are the downsides to using IABPs. I'm sorry, somebody said something?
Yeah, I had a question about the balloon pumps.
Yes, sir.
So there's like for the intra-aortic balloon pumps in after MIs and the SHOCK and SHOCK 2 trials, they didn't show any mortality benefits. Are there any?
So it's marginal, very marginal benefit. You're correct. There are more aggressive, and I was going to talk to you about that. There are more novel devices, left ventricular assist devices that are way more effective, such as the Impella, which is a pump implanted catheter-based pump implanted in the left ventricle that has much higher cardiac output, and hence the marginal benefit that balloon pumps have. These devices come with much more improved cardiac output support, but the problem is that the cost is super high, and the complication rates for these high caliber bore devices put transcatheter are super high too. So I agree, the balloon pumps have marginal benefit, but at times then that's all you may have. But if you have the option of more improved devices such as an Impella in a temporary form or an LVAD as a bridge to therapy or destination therapy, then those are more robust output support methods that you may use.
No, thank you.
And then, of course, transplantation will be your eventual goal, but as rare as heart transplant still is, because of paucity of hearts, the complexity of the surgery and the transplantation, we have to have some other options. Heart failure populations getting added by 500,000 a year, but we're not seeing 500,000 a year transplants being done, and that likely is never going to happen, right? So that's kind of what I wanted to talk to you about. Yeah, I just found this interesting. Guidelines don't think that sodium restriction is a big deal. Just thought I'll let you know. They think it's reasonable. They didn't think it was a huge deal. Some trial names here, just for you to review. Okay, that's kind of what I have for heart failure. I would like to give you guys about 2 or 3 minutes to grab a glass of water, use the bathroom if you want, and we will start with ACS. Please come back quick. As you can see, I have a lot of material to cover, and the sooner you come back, the sooner we can be done. So 2 to 3 minutes. If you have questions, stick around. I'm going to stay and answer them. Okay, hearing none, my chance to go get a glass of water as well. Guys, can everybody see my new slides? Wonderful. Yes. Are mostly people back? No, I don't see a few faces back. Okay, I'll give it another minute. Okay, everybody's back. We will get started. Our next topic for discussion today is acute coronary syndromes. Everybody can see the slides, right? Okay, so idea today is we'll identify patients with ACS, outline the diagnosis and management of STEMI and STEMI and unstable angina, and identify reperfusion strategies for all these patients, right? So, and these are some slides I love to show for all the budding cardiologists. This is the reason why you want to do this. For everybody who's not planning to the cardiologist, planning to be cardiologist, stop wasting your time and think of a career change. You know, over the last 40 to 50 years, life expectancy in the United States has gone up 8 years, and more than half of it has been due to improvements in management of cardiovascular diseases. So pretty much all the impact in the world has been made in cardiology. Everything else, I mean, you figured it out yourself. And as we look at over the years in decline in death from cardiovascular diseases, you will see all of these big trials that have made such big impacts. But the most seminal things that have happened are here. In 79, development of coronary angioplasty. In TIMI 1, using thrombolytics for acute MI patients. And then in 93, the proven superiority of PCI to thrombolytics in treatment of acute MI. So in all honesty, it's not even just cardiology. If you're not planning to be an interventionalist, you're wasting your time. So just rethink your careers while you can, okay? This is why this is important. 1.5 million admissions for ACS. Half of them are NSTEMIs, a quarter distributed between STEMI and unstable angina patients, all right? The problem is here. Death from admissions at 6 months in patients with acute coronary syndrome is still very high. Despite all the advances we made, things are better, but not perfect. STEMIs do definitely have higher mortality than NSTEMIs than unstable angina. I think all of you know the atherosclerotic plaque is the villain. We have looked at this villain many times in many forms. Formation of a lipid-rich core plaque with a fibrous cap. When the cap ruptures, the lipid core leaks into the lumen of the vascular structure where this plaque was, causing in situ thrombus formation. If it is a partial blockage, we get an NSTEMI. If it's a complete blockage and cessation of flow, we get a transmural infarct, or what is a ST elevation MI. If you have an unstable angina, non-STEMI, where there is not a complete occlusion of flow, we see on an angiogram something like this, an irregular ulcerated plaque, and an unfortunate histopathological specimen is going to look like this, where you have a thin fibrous cap, lipid-rich core, arterial lumen, point of rupture, where all this crap leaked out into the artery. You all know in ischemia, you're looking for an imbalance of blood supply versus demand in the myocardium, and the EKG response when you complain of angina with ST depressions and T-wave inversions. The ischemia can be two-sided. It can mean increased demand or decreased supply. Increased demand ischemia is not coronary disease per se usually, because this is usually due to either anemia, hypoxemia, heart failure, cocaine, drug abuse, fever, emotional issues, hypertension, thyrotoxicosis, all of these things. So if you have demand ischemia, then you got to fix the root problem here. But if you have supply ischemia, it is either due to formation of plaque or thrombus or plaque rupture or even vasospasm, then those are things you can address by trying to reduce the problems impacting the supply of blood to the myocardium. All right, so in injury, when you have transmural infarct, the entire coronary is occluded. Of course, you know you're going to be seeing ST elevations in the affected territory, the current of injury, right? So essentially, that's the basics of ACS. But now for the rest of this, we're going to talk about how we're going to evaluate and manage these patients. Now, I find that guidelines are seldom as clear in defining what any disease process needs as they are for acute coronary syndrome. In essence, what I'm saying is guidelines are bang on, are really down to the nitty gritty. They give you every little detail. So here from the guidelines, class 1 indication. When you approach a patient and think of ACS, always first assess the likelihood of CAD. Does your patient have some risk factors? Is the presentation fitting the ACS picture? Are these anginal symptoms? How long? What risk factors? Diabetes, smoking, cholesterol, family history. Look at the physical findings, look at the EKGs, and then think of biomarkers, okay? Very quickly get an EKG, usually within 10 minutes to presentation to the hospital. Know that if your patient came too early, your EKG may not show ST elevations if this is an acute MI or a STEMI. So if the first EKG is completely negative, but your clinical suspicion for MI is high, remember, wait 15 minutes and do another EKG. Okay, you can do this as often as you like. If your clinical suspicion is high, do not stop with the first EKG. This is the biggest crime we commit in the ER, when we do one EKG and it looks great and say, okay, that's cool, this is not a STEMI. First EKG may have been just too soon enough. Please, 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 your clinical suspicion is high, do a second EKG 15, 20 minutes down the line. Now, let's say your second and third EKG are bland as well, but you are so convinced that this is an acute MI, don't stop there. Add leads 7, 8, and 9 going to the back on the left side, because a high lateral MI or the posterolateral wall is blind spot for the regular 12 lead EKG. You know, your blind spot in your car mirrors where you don't see a car that's right next to you. This is the blind spot in your 12 lead EKG. You don't see the posterolateral wall or high lateral wall. And if your clinical suspicion is high, add lead 7, 8, and 9. So now you've done 2 or 3 EKGs, you've added lead 7, 8, and 9, you still don't see anything. Now you can be reassured that you don't have a STEMI, okay? Well, biomarkers, you should send in everybody, but often biomarkers are not the way you're going to diagnose a STEMI. If that's how you are, then that's too late. Your STEMI diagnosis should be available way before a biomarker result is available. Truman is shifting to high sensitivity troponin in less than 2 weeks from now. So in 2 weeks, you're going to start to see high sensitivity troponin instead of the regular troponins that you see. There is some education going around for that. If you have questions, ask me and I'll try and explain high sensitivity troponins to you. But the advantage of high sensitivity troponins are that they will pick up troponins at a very, very low threshold. So early diagnosis is possible, a more definitive diagnosis is now possible. And if your high sensitivity troponin is negative, you don't have an MI. The chances of having an MI with negative high sensitivity troponins are extremely impossible. So you got to measure biomarkers again, serially. In high sensitivity troponin, the separation of biomarker measurement is only 2 hours. In our regular troponins, it's more like 6 to 8 hours, right? So remeasuring positive troponins is of value as well to understand the amount or the infarct size or the volume of heart that is infarcting. Here is the timing of biomarker release. As you know, that myoglobin CK isoforms are the first to go up, but they are so not specific that this is not what we use for diagnosing MI. Cardiac specific troponins are what we use. And though a little late in being detectable in the bloodstream, they are way more specific, and that's what we use. CKMBs are also not that specific, and we hardly ever use them anyway. So troponins it is. Especially if a patient has had reperfusion with a PCI, you may see even higher levels of troponins. And that's the reason for that is that all that necrotic tissue that had troponins leaking, now you restore the blood flow, the troponin levels are going to be even higher. Now, troponin elevation is not an absolute. There can be many other confounding factors that you have to look for. Cardiac contusion, somebody came in with a motor vehicle accident and their troponins are high, could be cardiac contusion. Demand due to AFib, thyrotoxicosis, heart failure, all of those would be troponin elevations not due to plaque rupture. and think of severe aortic disease, aortic valve disease, hypertrophic cardiomyopathy, pulmonary embolism, burns, drug toxicity. All of these can cause troponemia. And then there is also, of course, kidney failure, which will decrease clearance of troponin, and you may see higher chronic troponins in these patients with renal failure. So you kind of have to put your clinical scenario into perspective before evaluating elevated troponin, okay? The one really good way of trying to understand risk of your patient is to do stratification with the use of risk scores. There are many scores out there. The TIMI is very simple, pursuit scores, but heart score, you guys use that a lot. But really, if you're trying to be cardiologist, the best score you want to use is the GRACE score and has the best statistics for use, and I'll show you. I put the TIMI score on here because it's so common and so easy. 7 components: age, risk factors, prior CAD, aspirin use, anginal events, ST deviations, and cardiac markers. These 7 components, you count them off as present or absent, and present is 1 point, and you add them up. You realize that all-cause mortality and recurrence of MI or ischemia in 14 days approaches 40% if your TIMI score is 6 or 7. Okay, so they're stratified as 0 to 2 is low risk, 3 to 4 is intermediate risk, and 5 to 7 is high risk. And this is important to know because the treatment for high risk versus the others is a little different. So you need to know your scores. Okay, there's a multi-marker approach where we look at troponin, CRP, and BNP. And then there's the GRACE score. This is what I really recommend you do. There's the distribution of GRACE score for low, intermediate, and high-risk patients. Know that your GRACE score cutoff for high-risk patients is 171. Okay. Now, what does it mean? It means that a high-risk patient, your in-hospital death rate is more than 9%. That's massive if you think about it. If 1/10 of your patients are going to die in the hospital and never get out, that's a very high GRACE score. Make note of that. Okay. Here's how the risk scores compare, TIMI and GRACE. If you see, TIMI is more history heavy, GRACE is more presentation feature heavy, okay? And again, the reason I propose the GRACE score is when you compare the relative predictive accuracy, the GRACE score tops other risk stratification scores available for ACS patients. So use your GRACE score, okay? Of course, there's apps on your phones or on the web that you can use to get to these quickly. You don't have to memorize them. Just key in a few features and it'll throw the score at you. Okay. Remember, GRACE score of 171 is high risk. So let's discuss a case. This is a 65-year-old man who was a diabetic and hypertensive, and he woke with chest pressure, and he was driven to the emergency room 1 hour later when the pain did not go away. Okay. So now, is this patient at a risk for ACS? Anyone?
Yes, he is.
Yes.
Yeah,
Diabetes, hypertension.
absolutely. Many things, like you said. He's 65, he's a man, he's diabetic, he's hypertensive, he was woken up with chest pain that isn't going away. Every feature here suggests ACS. So what information is now needed, next steps, to figure out what you're dealing with and what do you do?
Try the pain, get more history.
Well, can you speak louder?
So characterize the pain, get more history from the patient, and then do vital signs, then physical exam, then order initial EKG tropes. Perfect. And just you can give like a sublingual nitroglycerin to.
Excellent. So I think really what you need next is you need an EKG, right? Because if you have an EKG, there's no ST segment elevations, and you've done your repeat EKGs when you're dealing with NSTEMI or unstable angina. But if you have ST elevations, then your whole pathway is different, right? So your EKG is the next key thing. Like we said, do it within 10 minutes. So here's the EKG. I have the vital signs you asked for and the physical exam you asked for. It's on the screen. What do you guys think?
There is like
and
a version mainly in the anterior leads.
So you're right, anterolateral leads, some TV inversions, maybe some ST depressions, but no ST elevations. So you're looking at, like Ruben said, probably an NSTEMI or unstable angina picture. So what do you do next?
Repeat in 15 to 30 minutes. Get a
Excellent. Looks the same, trope is cooking. What do you do next?
325.
Say again.
Risk stratify.
Risk stratify. That's a good thought. Excellent thought. Risk stratification is important, but there's a few. there's a few things that you can do immediately is start thinking of antiplatelet, anti-anginal, antithrombotic therapy. Okay, these three key components are in your hands right now. You have clinically determined that this is an ACS picture. Okay, so you can, barring any contraindications, you can start to give some therapy to this patient. And antiplatelets would probably be first, aspirin, absolutely, and then think of your next strategy in terms of anti-anginal and antithrombotic agents. So let's talk about these a little bit. So platelet-mediated thrombosis occurs, as you know, platelet has three stages of its mediation and thrombosis. The first is the adhesion to the endothelium. The second is the activation, where it expresses all these receptors. And the third is the aggregation, where it binds to more platelets, forming a platelet plug, right? Now, we really don't have any drugs that target adhesion, but pretty much almost all of our drugs target activation. Aspirin, the P2Y12, sticlopidine, all of them target the activation stage of platelets. We do have the 2B3A inhibitors, GP2B3 inhibitors, which is your eptifibatide, tartyrofiban. These do target the aggregation phase. Okay, so we have good effective therapy for two stages of platelet mediation and absent for one. When you find the adhesion therapy, you're going to get a Nobel Prize. I tell you that because that's really sought after right now. So in platelet activation, you have the P2Y12s acting through the ADP pathway, the aspirin through the arachidonic acid pathway. Then you got the heparins, low molecular weight heparins, the direct thrombin inhibitors through the thrombin pathway, and then the GP2B3A inhibitors through the 2B3A receptors, preventing binding to other platelets. Okay. Now, I do want to point out the differences between three of the popular drugs, P2Y12s, that we use. These are clopidogrel, prasugrel, and ticagrelor. The difference here, the main difference here is clopidogrel is like a prodrug, requires hepatic enzymes to oxidize it and turn it into an active metabolite to cause platelet inhibition. Ticagrelor is an active metabolite and doesn't need that. And prasugrel, though not an active metabolite, has a one-step oxidation process to the active metabolite that does not need the liver enzymes. So why is this important? Because liver enzymes can be played on by other drugs that inhibit or enhance the liver enzyme activity, or the liver enzymes may be genetically different activity, causing different reactions to clopidogrel. So if you have enzymatic deficiency, your clopidogrel may never reach the platelets. Or you're using other drugs that mess with this, your clopidogrel may never reach the platelets. Whereas ticagrelor and prasugrel don't have that problem. Okay, so when possible, if its cost is not an issue, I would rather use one of these two drugs than this one. Okay, the other thing is, if you look at this, clopidogrel in its high dose, 600 milligram loading dose, takes 6 hours to inhibit platelets effectively, whereas these drugs take 1 to 2 hours. So you have more instant platelet activation inhibition with prasugrel and ticagrelor, and you have a long onset time from clopidogrel. Okay, so another reason why clopidogrel wouldn't be my first choice in these drugs, these patients. Again, if you use a lower dose of clopidogrel, that duration is even longer, 12 hours. You could still use it if you're in no rush. If your patient isn't going to go anywhere for another day or so, you could use the 300 milligram dose, but I would prefer the 600 if you were using clopidogrel, but I would rather prefer ticagrelor or prasugrel if your patient is truly an ACS. So, I kind of try to simplify this every time, and it gets more and more complex. I think I can say this better than I can put it on a slide. So if your patient with acute coronary syndrome has medical therapy or PCI planned, you are going to use dual antiplatelet therapy for 12 months, heparin for the first 48 hours or till PCI is done, whichever comes first. Okay? If you have bypass planned, the heparin requirements stay the same, but you want to stop your DAPT therapy, your second agent of your DAPT, at least 5 days before surgery, because otherwise the bleeding risk is too high. Okay? Does that make sense? So DAPT for 1 year, whether you're going to do PCI or no PCI. DAPT for 1 year. Heparin for 48 hours or till PCI, whichever comes first. And if it's going to cabbage, then stop your DAPT, second agent DAPT, at least 5 days prior to cabbage. Okay, that's kind of all I wanted to say to that. But now there are studies that show, the DAPT study in 14, PEG study in 215, that said that in certain population, longer DAPT than 12 months is beneficial. They made these scores that looked at patients in different perspectives, and you can look these up. You can look at the precise DAPT score, which include these characteristics: hemoglobin, creatinine clearance, age, prior bleed, white count. Or you can look at the DAPT score, which looks at diabetes, smoking, age, prior MI, and heart failure. And it puts together this information to give you whether your patient is at a higher bleeding risk or higher rethrombotic risk. If your patient is higher rethrombosis risk, you continue the DAPT therapy for longer, 30 months. If your patient is higher bleeding risk, you stop it at 12 months. Okay, so using these scores to tell you, I ran a hypothetical patient here to show you. Okay, using these scores to show you the balance between thrombotic risk and bleeding allows you to decide if DAPT therapy should be continued beyond 12 months in ACS patients, up to 30 months. But what if, for some reason, you needed shorter DAPT? Patient is going to surgery or has high bleeding risk. The current recs are 12 months, by the way. The guidelines will say 12 months. Do not shorten for ACS patients. But there are many trials out there that are looking at this and saying that, okay, mostly in current generation stents, 6 months should be fine. And even 1 month is okay, acceptable. Mostly people do okay. Okay, but these are not in the guidelines. These are trial data. Okay, so 6 months may be okay. 1 month could be okay, but guidelines still say 12 months. Okay. So this is kind of the overview of what I just told you, that if you have an ACS patient, whether you use medical therapy, whether you use lytics, whether you use PCI with BMS or DS, or whether you go to cabbage, you have to use 12 months of DAPT and possibly longer based on your DAPT score, up to 30 months. This arm is your ACS patients. Okay. Now there are some don't do's in your ACS patients. These are: don't use nitrates in patients with RV infarct, or especially those who are taking Viagra or phosphodiesterase inhibitors. That'll cause lots of hypotension and your patient could collapse. Don't use immediate release dihydropyridine calcium channel blockers. Do not use IV ACE inhibitors. Do not use IV beta blockers routinely either, especially if your patient has hypotension or heart failure. So IV beta blockers used to be a common thing. And one day I called an ED physician, a leading ED physician here at Truman. And I said, the patient, they told me about the patient. And I said, okay, why don't you give 25 milligrams of metoprolol? And they said to me, IV or PO? Okay, so think about 25 milligrams of IV metoprolol. That would have killed the patient. Okay, there used to be a time when older ED physicians favored IV beta blockers in these patients, but no longer the case. Do not use NSAIDs other than aspirin. You just increase the risk of GI bleed. You should give oral beta blockers as long as there is no bradyarrhythmias or heart failure or shock. You should use oral beta blockers in these patients, not IV. Okay, so back to your patient. You know, your unstable angina and STEMI patient. Here's all the things you'll do. You'll admit the patient. You do EKG, oxygen, aspirin, clopidogrel, nitro, morphine, heparin, beta blocker. So you're doing anti-anginal, anti-thrombotic, and antiplatelet therapy. Those 3 things. Okay, anti-anginal in terms of morphine, nitroglycerine, maybe even oxygenation. Antiplatelets is aspirin, clopidogrel, and anti-thrombotic is heparin. Right. So you got to do these 3 things for your patients, no matter what. Now, what is your next step? So when we were discussing this before, one of the things you said, Mael, was we do a risk stratification, right? Now is the time to do that. First, you got to do your antithrombotic, antiplatelet, and anti-anginal therapy. And next, you do risk stratification. Because if it's a high-risk patient, they need PCI within 24 hours. And let's talk about that. So, you know, forget this. I put the slide here to show you what is high risk versus what's low risk. But really what it is, it's your Grace or Timmy score put in the form of words. Okay, so just stick to your scores. If your score is high risk, your patient is high risk. So a lot of data has been looked at to what's the answer. Do we treat these patients conservatively or do we take them to the cath lab? And overwhelming data supports that you should take the patient to the cath lab and you should do it early. Okay. Whether we look at all-cause mortality, whether we look at recurrence of MI, or whether we look at recurrence of angina, in all cases, taking the patient to the cath lab, the patients did better. No two ways about it. Now, if you split your patients by risk profile based on scores, and you did high, intermediate, and low risk patients, if you're high risk patients, the evidence was clear, and even in your intermediate risk patients, the evidence was fairly clear. When you got to your low risk patients, even though invasive therapy was better, but that's where the difference was a little less marked. Okay, but if you looked at all together, going to the cath lab is always the right answer. The second question was, how fast do we need to go? So ISAR-COOL looked at taking the patients to the cath lab within 6 hours or waiting 3 days before taking the patient to the lab, cooling the patient off for 3 days. And clearly, the cooling off patients did a lot worse. More people died. So what we knew is waiting 3 days is not the answer. Then another study looked at 24 hours versus 36 hours and found that when we looked at these patients, the difference in all patients was not remarkable. The difference in low and moderate group patients was not remarkable. But when you looked at the high-risk patients, there was a difference. Okay? So in essence, what this told us was that when you have a high-risk patient by your scores, you want that patient in the cath lab within 24 hours. If it's not a high-risk patient, it should be no longer than 72 hours. Okay? Another trial looked at, what if we treat all patients like acute MIs and take them to the lab within an hour? That really didn't improve outcome. So taking NSTEMIs to the cath lab within an hour or two didn't improve outcome, did not. So in essence, what you should take away from this is that everybody gets to go to the cath lab. A routine early invasive strategy is better. And super rush on high-risk patients within the day, 12 to 24 hours to the lab. Okay? And heavy reliance on using risk scores. Can't emphasize that enough. Okay. So I have a patient here who came in with chest pain after initial relief with nitro and metoprolol, and the EKG is obtained, and it's in front of you. Does anybody want to take a crack at what you see?
There is an ST segment elevation from V2 to V6, which is extensive anterior MI.
So it's an anterolateral MI because you see it here in AVL V6 as well. And then you have ST depressions or reciprocal changes in inferior leads. So this is an anterolateral acute MI, right? What do you do next?
Take him to the cath lab directly.
Think one more time. What do you do next?
Start an antiplatelet reperfusion therapy.
Absolutely. So don't forget anti-anginal, antiplatelet, and antithrombotic therapy. That's got to start now. The cath lab, I'm sleeping at home. By the time I get dressed and drive in, it's another 30 minutes. Okay? You can do a lot till then. So ruptured plaque causing a thrombus, full occlusion of flow. This is what it'll look like on an angiogram. And here's an unfortunate histopath specimen where you've had the fibrous cap broke, the contents leaked into the coronary and thrombosed the entire vessel and caused complete cessation of flow. Another slide specimen showing you very nicely the fibrous cap, point of rupture, lipid-rich core, and thrombus completely occluding the coronary, right? So you're going to do your things. Now, what is the next step?
And the cath lab.
Absolutely. So we have to restore flow. So you have a couple of ways you can restore flow. You can do it by cath lab, by thrombolytics, or by bypass. I'm not sure why they keep saying bypass, because nobody's going to go to bypass without first going through the cath lab. If it is unreperfusible by the cath lab, sometimes the patient will go to bypass surgery, but 99.9% of the patients will be handled in the cath lab. Unless a cath lab is not available, then you have to think of thrombolytics. So if you can get the patient to the cath lab in a timely manner, either on-site or even off-site, then cath lab is always the preferred modality. If you do not have an option for the cath lab within hours, then your patient may be a candidate for thrombolytics as long as there is no contraindication to thrombolytics. So when is PCI preferred? If there's no contraindication to, if there's contraindication to thrombolytics, you don't have a choice. You need PCI. If cardiogenic shock is present, PCI is more preferable. And then if you have a cath lab within timely access, PCI is more preferable. When is thrombolytics considered? If you are within 3 hours of onset of pain, but no more than 6 hours of onset of symptoms, and there are no contraindications to thrombolytics. Okay? So you can consider thrombolytics for these people. But here's the problem with thrombolytics. Almost a 1% risk of massive intracranial hemorrhage causing either permanent debilitation or death. Okay, that is bad. 1% is pretty bad. Okay, so when they look at all these trials and combine them and look at death, reinfarction, stroke, or total stroke, and compare lysis with PCI, every time PCI is way more favorable. So lytics are only reserved if PCI is not available and there are no contraindication to lytics. After reperfusion, though, everybody should get beta blockers and ACE inhibitors and dual antiplatelet therapy after PCI. After thrombolytics, heparinization, because the clot is broken down, but the ruptured plaques is still there, so more clot can form. So after thrombolytics, you still have to give heparin, but after PCI, you do not have to give heparin. So things are looking good. Over decades, primary PCI is going up, thrombolytic use is coming down, but it's not gone. Okay, and as we use better and better drugs, we see that our patients are improving in morbidity and mortality with acute MI. Each addition to our understanding of treatment of ACS has improved the survival. But here's also the key thing. We keep saying the 90 minutes door to balloon. This is because when we get past about 100 or 120 minutes, every 30-minute delay increases the 1-year mortality by 7.5%. So that 90 minutes is really, really key. So you will have to hurry, but don't make haste. So if you have an acute MI on your hands when you're on the floors or in the ER, be methodical about how you approach that patient. If you have two of you, divide and conquer. One person reviews the chart, the other person manages the patient. Call the cath lab team, etc., etc. But what I'm really trying to say to you is that time is essence. Every half hour wasted is a 7.5% increase in 1-year mortality. For those of you who have had the opportunity to see us in the lab, you'll realize we're doing exclusively radial cases now. The data is showing that the radial approach to ACS patients is huge mortality and bleeding benefit. So radial is the de facto method for ACS treatment now.
Sorry, what's radial mean?
Oh, sorry, a radial approach instead of, so arterial access, instead of going anywhere else, we now go into the radial artery. Traditionally, it was the femoral artery or the cut down of the brachial. It seems intuitive to give oxygen to patients with ACS, but there's now a reasonable amount of studies showing us that higher doses of oxygen are actually detrimental. High mortality in med-surg ICU patients if randomized to PaO2 greater than 100. And then in MI, in the VOID trial, they showed larger infarct sizes if the patients were on high flow oxygen. And in the detox trial, they showed STEMI patients, if they were randomized to 6 liters versus room air, there was no difference in mortality. So basically, when you get to high levels of oxygen, you actually cause harm. And if your patient's oxygenating well, keep them at room air. Okay, so I have another patient scenario for you. Patient had a PCI with an LED stent, developed dyspnea, rales, and hypoxemia 1 day later. Here are the vital signs. Okay. So what is the complication and what do you do next? And the answer doesn't have to be one. It can be more than one.
Could be an arrhythmia, pericarditis, fusion.
So the most common things first, you're likely dealing with heart failure. But you're right, it could be a pericardial effusion. It could be valvular dysfunction with severe MR, papillary muscle rupture. It could be free wall rupture. It could be a VSD. Those are all the potential complications of an acute MI that you should be aware about, right? You examine the patient. What you need then is a quick bedside echo to understand what complication you're dealing with. And hence the advantage of learning the echo skills that both Dr. Gohar and myself we have been focusing on, right? Getting you to be comfortable with echo skills. Okay, here's another patient. Chest pain, blood pressure 90/50, lungs are clear. You called the cath lab already. This is your EKG. What do you do?
IV fluids and avoid nitrates.
Perfect. That is exactly what I was looking for. This is an infarct, RV involvement, hypotension. The answer is fluids, avoid nitrates. Now, often people will tell me, what if you have an aspirin allergy? What do you do? You know, too bad. Use a single antiplatelet agent and go on. The acute MI does not wait for you. What if you have coffee ground emesis? Too bad. You go on. The acute MI does not wait for you. You can transfuse blood. You can get a GI doc to find and cauterize a bleeder, but you can't do anything with the heart once it's dead. What about severe heart failure exacerbation? Actually, the guidelines will tell you that if you are in decompensated heart failure, immediate PCI is the better answer. What about patients with renal failure not on dialysis? Too bad. Once the heart dies, there's no other option. You do have dialysis, but you can't replace the heart as easily. So if you have all these excuses of why not to take the patient to the lab, rethink, because the heart is a vital organ with no replacement strategy. That's easy. What about out of hospital cardiac arrest? You know, more than half the patients will be comatose on arrival. Now, actually, they have better survival if they had VT-VF, because that is clearly an ischemic rhythm and you fix it and the problem is good. If it's PA arrest, that's bad. Survival rate is overall low. It's only a quarter of these patients that are going to survive. With hypothermia and PCI, these rates can improve to about 2/3 almost. And of that, most will have a favorable neuro outcome. So here are some, statistics for you. Very low mortality if they're awake, but high mortality if they're not. So I just put here something that is a very commonly asked question. What if your patient has an anticoagulation need such as AFib or PE or whatever, and you have ACS? What do you do? So our default strategy is around the PCI, do triple therapy. By triple therapy, we mean aspirin, ticagrelor or Plavix, and anticoagulant either as DOAC or Coumadin. Okay. And then immediately after the PCI, we stop the aspirin, continue the oral anticoagulant and P2Y12 for the next 12 months. This is our default strategy. If patients are at a high ischemic or thrombotic burden, we can continue the triple therapy for 1 month. If the patients are high bleeding risk, we can stop the double therapy after 6 months. Okay, so this is your method of handling patients with ACS with a need for anticoagulation, either due to AFib or PE or a clot somewhere else.
Dr. Baweja, quick question.
Yeah.
What INR, how high an INR can we tolerate before going to PCI?
Yeah, so the INR still remains in the therapeutic region because, as you realize, for a thrombus, the INR requirements are not going to be any different because the antiplatelet agent is on board. So your INR requirements don't change for Coumadin patients. What we're trying to do here is lower the bleeding risk.
Okay.
So that's kind of all I have for you guys.
I had one other question.
Yes, sir.
We usually face a scenario at Truman where we think that if the patient is going to get DAPT and he's possibly going to get a stent. He needs to get DAP for another 12 months. The choice between ticagrelor versus clopidogrel. So I've been told that, you know, this patient cannot afford, it's better to start with clopidogrel. But then from the table that you showed us, it seems like ticagrelor is always a better choice. So can we put the patient with ticagrelor and then continue clopidogrel after the PCI or no?
Yeah, so very commonly we will do this, that in the PCI we'll use the ticagrelor and then convert them over to Plavix by reloading them. So you have to reload them. And you can convert either ways. You can convert to any of the 3 drugs. You just have to reload and reinitiate therapy.
Okay.
Ticagrelor loading is 180. Plavix loading can be 300 and 600 based on desired timeline. And I think prasugrel loading is 60.
Okay.
All right. Very good, guys. Thank you so much for joining me today. Now, this is a lot of information. I'm a little hoarse going through all of this, but Dr. Gohar is a taskmaster, and he insists that I do these lectures back to back and go hoarse giving them. But I can imagine that your questions may not be all framed, and you may think of something later. If you have questions later, please, all of you know how to reach me. I would love to hear back from you. I really mean it. So email or come and meet up with me, and we can talk about anything you like.
Thank you very much, Dr. Baweja. So great lectures as usual. And I don't know if all of you know, that Dr. Baweja was Teacher of the Year a few years ago. And he is a great lecturer. And I think, Dr. Baweja, you use your TMC email more than UMKC.
Yes, either would be fine, actually. Either would be fine.
Just I have one question for Dr. Baweja. Can you explain to them how to activate code STEMI?
Absolutely. That's a good answer. So, you know, what we do prefer is that if you have an ST elevation MI in the hospital, that you do not activate code STEMI directly. What you do is you call the interventional attending on call and tell them what you have and let them activate it. There is a direct phone number to call the interventional cardiologist. Okay, I can even share that number with you, or you can ask the operator and say, connect me to the interventional cardiologist, and they have a direct number to connect us to. But let me see if I have that number handy, and I can actually share it with you. You know what? What I can do is I can always message. Oh, here it is: 816-547-4394. I'll repeat it: 816-547-4394. If you call that number, you're going to have the interventionalist on call answer your phone immediately. So no time is wasted. You call the number, tell them, hey, I think I have a STEMI on my hands. They'll probably say, okay, take a picture and text it to me or whatever. And if you have a picture already ready, it'll make things faster. Go do that and you're on your way very quickly. Usually this process takes less than 2 minutes.
Any other questions for Dr. Baweja?
Thank you all. It was a pleasure talking to all of you. I'll see you around.
Thank you very much. And
thank you, Dr. Gohar.
Thanks, Dr. Baweja.
For all your great lectures. Okay, I think we did not get enough time for the break, so we'll give you a 5 minutes break until Dr. Mustafa joins. Dr. Baweja finished a little bit early. This is unusual for Dr. Baweja to finish earlier than the time, but thank you for finishing earlier. And then just 5 minutes and come back.
I did not get interrupted. I was so surprised. No questions at all.
Okay. I think we had some discussions, nice discussions.
Usually I do get interrupted a lot more than that.
I think we have smart group this time.
That must be it.
Okay. So you can get 5 minutes break, then come back. People, if you are not requiring break and you want to have, if you have any questions for me after now about the course, anything you want to share, please feel free. Looks like no. Okay. We have one more lecture for 1 hour by Dr. Mustafa. This is about electrolyte imbalance, which is a good lecture, and usually one of the things that you'll see a lot in your ICU. We'll wait for Dr. Mustafa to join. Okay, I'll put some music until people return. Yes, well, this is Omar Khairat concert.
So you guys are listening to Omar Khairat as a break? Hello,
Dr. Mustafa, you joined? Okay.
Yeah, hi Ashraf.
He's giving some music during
It's some music, and it's really good music. You have a good taste.
Thank you. So now I hope everybody is back from the break. So Dr. Mustafa joined us, and she is a great teacher. She's another teacher of the year when she was here in UMKC before she moved to KU. And she is nephrologist in KU, and she is also one of the best teachers. She is doing this lecture for many years with us. And thank you, Dr. Mustafa, for coming. Would you like to share your screen? It would be great.
Sure. Well, it's my pleasure to be with all of you today. And thanks for having me be with you. I'm sharing my screen now. And I don't want this. Okay. So let me see here. I see some of you have your cameras on, not everybody. I'm going to ask you to make this as interactive. I know it's the end of the day, and I hope in the break, as you were listening to music, you took a break and stood up and took some, just moved. But feel free to stop me, ask questions at any point. This is as useful as you guys can make it. I'm very happy to be here with you, and I also happy to receive questions after, so Dr. Gohar can always share my email with you. I'm going to start talking about total body water. So 0.6 or 2/3 of our weight is water, and of that, 1/3 is...
I don't see, I just see white screen. Does everybody can see the screen?
No.
Yeah.
All I can see is white.
Right.
Okay, let me stop sharing, and I'm going to share one more time. Let's see if it works now.
It works now. Thank you.
Okay, well, thank you. But you can hear me okay, I'm assuming.
Yes, we hear you and see that your slides, yeah.
Okay, perfect. So 2/3 of our body is water, 1/3 is extracellular fluid, and 1/3 is, 2/3 are intracellular fluid. And then when we think about the extracellular fluid, the majority is actually interstitial fluid, and only 1/4 of that is intravascular. I also want you to keep in mind the composition of electrolytes, both in the intracellular and extracellular compartment. So, and it's very easy. It really depends on what you see when you do a blood test. So the majority of the sodium is extracellular, no surprise. This is the normal range. The majority of your potassium, on the other hand, is intracellular. Again, no surprise. Same thing with phosphorus. So phosphorus and potassium are mostly intracellular. We're going to talk about a few cases. So our first case is Mr. Smith, who is a 70-year-old male with end-stage kidney disease due to hypertension. He is admitted with pancreatitis. He did not tolerate enteral feeds and is on TPN now. He complains of his legs feeling weak. And here are his labs. So I want one of you to tell me, when you look at the labs, what catches your attention?
Hyperkalemia.
7.4.
Excellent. And that was Ruben, right? Okay, hyperkalemia, very good. So when you see this, what would you do first?
So I had a similar case before. So basically, if the patient is on TPN, I'd first double check with the nurse if she got the sample from the line where, on the same arm where the TPN is running, and then repeat the potassium or get an EKG as well. So, and then double check the result again.
Okay, wow, great. So I'm going to get an EKG. I fully agree with you. You want to confirm the results, but with potassium that is above 7, I'm just going to really act on it. So, and now my EKG shows peak T waves. So what do you want to do now?
Calcium
gluconate.
IV and insulin and NDP.
Okay, Nisha and others, thank you. Calcium gluconate. I'm going to give bicarb because he was acidotic. I'm going to give insulin and glucose. And I am going to stop his TPN, okay, because I'm suspecting this is the source of his potassium. And the next question, if you called me for this case, my first question to you would be, is he making urine? Because my management, I'm much more relaxed as a nephrologist if they're making urine. So if you think about hyperkalemia, it happens when there is a decreased ratio of the intracellular to extracellular. So that means that more potassium is being shifted to the extracellular fluid. And there are different things. There is depolarization that excites the tissue. There is conduction velocity that decreases, and increase in rate of prepolarization. And these are the different manifestations on EKG. So we start from normal here. The first thing we see is peak T wave. Then we see the prolonged PR. Then we see the complete absence of PR. And then you see the increased spread, and then you end up with the sine wave pattern. Okay. One thing to keep in mind, again, hyperkalemia is a potassium of more than 5.5 or whatever the upper normal in your lab. However, I really get concerned when the potassium is above 6. So typically below 6 you can manage for the most part, unless they're like 5.7, and I know, for example, they have tumor lysis syndrome, or they have rhabdomyolysis, or they have something. So I know that this is going to actually keep going up fast. So just kidney failure is the leading cause, and that patient actually did also have acute kidney injury. It can be life-threatening due to risk of ventricular arrhythmias, and it is the most fatal electrolyte imbalance that we all deal with. Normal renal response to hyperkalemia is that it stimulates aldosterone secretion, which then stimulates urinary potassium excretion. So you see why I'm asking about if they're making urine. And this we can see, and it works if they actually have normal kidney function. Symptoms of hyperkalemia. You can see patients complaining of skeletal muscle weakness, paralysis, paresthesia, respiratory failure. And the causes of hyperkalemia, we start with decreased renal excretion. So that mostly happens with a reduced GFR, increased intake. And the intake, as you saw, a lot of the time, it's not really oral intake that they're receiving it, but also a lot of the salt substitute have potassium. So you find the patient and they tell you, I'm very strict, I don't eat any salt and so on. That also should always bring, you should ask them, what are you using instead? And then there is the transcellular shift. So metabolic acidosis, that helps with the shift of potassium outside the cell. Again, through tumor lysis syndrome, rhabdomyolysis, all these help with this shift. And then there is the aldosterone deficiency or resistance, which can lead to hyperkalemia. Common drugs. So drugs. I'm sure ACE and ARBs are very high on your list, but we have spironolactone, we have amiloride, cyclosporin, tacrolimus is a common one for patients who are on, who have transplant. Heparin, rare, but can be seen. I've actually seen it in multiple cases. They usually have transient hyperkalemia while in the hospital. Pentamidine and trimethoprim, sulfamethoxazole. Okay, reasons for potassium to have shifted outside the cells. So it shifts outside after blood was collected. So there is hemolysis, the sample is hemolyzed, and there is a tissue hypoxia distal to tourniquet. And then the question then, are the kidneys excreting potassium appropriately? So if it wasn't just outside the cell after blood was drawn, is it actually, are the kidneys excreting potassium appropriately? And in many times they're not. If again, drugs can cause that low GFR, so chronic kidney disease or acute kidney injury and aldosterone. Okay, excessive dietary potassium intake contributing to the problem. Again, always think of your IV fluids and TPNs. Treatment. So the first thing, one of you already mentioned that, is to repeat the potassium. You get your EKG stat, and if there are any changes, you're going to start treatment immediately. Progression of change is important. So I showed you how this happened, but whenever I see any change, it's not like, oh, it's only peak T wave, so I'm gonna sit there and be relaxed and calm because they have a long time before they reach the sine wave. That's not actually true. Yes, they progress, but that progression can happen fast. And you see here really the progression, which we already looked at. Treatment is, again, you have to stop the potassium intake. Look at anything related to EKG changes. You want to stabilize the myocardium, and that's why many of you said, I'm going to start by giving calcium appropriately. And then you want to shift the potassium inside the cell. So that's why we give the insulin and glucose, beta agonist, and sodium bicarb. All these are just shifting measures. And then you want to remove it. You want to get rid of the excess potassium, right? So diuretics, loop diuretics, or specific medications or hemodialysis can all help. We get this very often. If you actually know somebody is going to be on the dialysis machine, so they're end-stage kidney disease patient who comes into the ER, now their potassium is 8. We sometimes tell people, if they're going to be on the machine, we want the potassium because we want to get rid of it. We don't want to shift. But if you have any doubt, the nurse is not yet there, we don't know when they're going to be on the machine, it's okay, shift them. What happens is sometimes we have to repeat the dialysis again the next day because, a lot, but still treat it, don't wait, especially when it's too high. This is a slide I believe I started sharing just not last year, and it's really important, okay? So This is about hyperkalemia treatment and the use specifically of K-Exalate. It is clear, there is no question, that there is association with increased relative risk of intestinal ulceration or perforation, about 2 times increased risk. But though the absolute risk is very small, so it's about 1 in 1,000 patients, okay, that will have perforation. But if you think about how many times you order K-Exalate, you know, this is one of the rare complications that you will see during your career. Increased malpractice cases, we've seen it in the nephrology community, especially if a K-Exalate have been given to one of the high-risk patients. So the consensus now is to avoid K-Exalate, okay, especially in post-op patients, patients with ileus, bowel disease, including IBD or C. diff, bowel obstruction, or anyone receiving opiates. Well, I know that covers a lot of our patients. So dialysis should be done instead of giving K-Exalate unless it cannot be performed promptly, okay? So shift priorities in our already overworked dialysis units. So a lot of the time, I know at KU and I'm sure at Truman and St. Luke's and all the hospitals, you know, sometimes all my dialysis machines are full. I'm trying to manage this patient until I can get them on the machine. So a really good option is zirconium silicate, that's Lokelma. It is not FDA approved for acute use, however, it does work. It works within an hour. So it really helps with lowering the potassium acutely if you're trying to find a solution. And I'm not gonna talk much, but Patiromir or Veltasa is a really good outpatient option. We are using them, we're using these medications even outpatient, but for you in the ICU, you can use Lokelma until somebody, especially if a patient is not making urine and you're trying to manage it until they can get dialyzed. This is the goal of this slide is just to remind you that the onset and duration of different treatment is different, okay? So the one that works the fastest is giving them calcium. Then comes the bicarb. That's why we give bicarb during our codes and we give calcium during our codes. And then these other treatments, the onset of them working takes longer. Some of them also, the effect lasts longer. So again, if you give calcium, doesn't affect my dialysis much. Bicarb is okay. I can still, if I'm dialyzing them more than 2 hours, I can still deal with it. But you know, when you give insulin and glucose, it's gonna take longer as an effect. So just keep that in mind. Stop here. Let me finish the second case and then I'll open for questions. Second case is a 23-year-old woman with no significant past medical history who comes to the ER with weakness, okay? Her lab show a potassium of 2. So we're gonna talk about hypokalemia. Now, hypokalemia is the opposite, is potassium is less than 3.5 milliequivalent per liter. It is a life-threatening, it can be life-threatening if the potassium is below 2.5. A most common cause in the ED is diuretic, and sometimes malnutrition with elderly people. Other causes is there are renal losses, okay, especially if you have some RTAs, magnesium deficiency, but there is also GI losses, nausea, vomiting, diarrhea are pretty common. Now the symptoms, weakness or paralysis, ileus, cardiac dysrhythmias, and here are the way you see it on EKG. So this is normal. Then you see like flattened T wave, the opposite of peaked. Then there is the appearance of the U wave, and then there is the depressed ST segments, and then you see the flat or inverse T wave and the prominent T wave. So you see this, okay. Hypokalemia treatment. If the potassium is more than 2 and there are no EKG changes, you can treat orally. If it's below 2 or there is EKG changes, then you need to treat intravenously. You need to monitor potassium value until normal values is established. So it's not, whenever you're replacing potassium, you should repeat and make sure it is being corrected. Same thing with the hyperkalemia, you should repeat. So let me stop here and just see if you have any questions about potassium management.
I have a question about the timing to repeat the, I mean, if there's hypokalemia, I'm gonna replace, or there is hyperkalemia, I'm gonna treat. When I'm gonna repeat the next lab?
Excellent question, Suhaib. So I repeat the labs depending on the number. If there, for example, if it's a potassium of 3.1, it's not in the critical range, and I'm replacing the potassium and I'm replacing it orally, I give them around 6 hours before I repeat. So I want to give them time to absorb and I want to see the effect. Okay. If I'm treating hyperkalemia, okay, it really depends. If I treat the hyperkalemia and then I start them on dialysis, I don't necessarily repeat potassium until after I finish my dialysis by actually around 3 hours, because you want to give time for equilibrium to happen to confirm. Okay. However, if I'm treating hyperkalemia for somebody who I'm giving diuretics for example, they don't need dialysis, they're making urine, and I'm going to treat with diuretics, I would repeat it in 2-3 hours. If they're making urine, I will repeat in 2-3 hours. If they didn't make urine, I would repeat it faster to see where am I and what to do next. So really the decision is a dynamic one, depending on the level, how high or low your potassium is. If you're replacing, how did you replace? If you replace IV, you can check it, shortly after replacement with IV. But if you give PO, you need 4 to 6 hours after. And if you're treating hyperkalemia, it's how did you treat it? I do with Lokelma, especially when people in the beginning, when we started using it kind of a couple of years ago, a lot of the services were just not comfortable. They're not used to it. So I would check it in an hour to show them that it went down. But yeah, you will never be faulted for checking it too close, as long as you manage correctly. The one time I discourage people to check very close is right after they get dialysis done. Because what happens is with those patients with hyperkalemia, I dialyze them against a potassium bath. Most of the time we use 2. Okay, so I'm only so if you check somebody's blood right after they're done with dialysis, the potassium is going to be low. I promise you that it will, no matter what, because they were dialyzed against that bath. So give it a couple hours so you're not in the fall. And I've seen this where people checked it too close and now replace potassium for a patient on dialysis because it was too low. You don't need to do that.
One more question. I mean, look, for example, you have a patient admitted for heart failure exacerbation and you are diuresing, and every morning you check the labs and he's hypokalemic and you replace. Like, which point you will decide I'm gonna just schedule potassium for him? I'm not gonna just wait for the labs every morning. Which one is better? Just wait for the morning labs, or like schedule?
Yeah. Great question. Many of our patients in outpatient are actually on potassium supplements with diuretics, right? So it depends. If you're actively diuresing with a higher IV dose, you might kind of put him on a scheduled dose, let's say 40, but you might want to check and make sure that's enough, If you're actually continuing their outpatient dose of diuretics and they're 2-3 days in a row they're hypokalemic, I would replace. But again, I would try to find out why. If they weren't hypokalemic outpatient, what happened now? Is it that we're controlling their food? Are they non-compliant outside? And so this is where I see things that can go wrong. I don't want to put them on a replacement unless I find out what is it that we're doing differently, because I don't want them to be hyperkalemic. Very good. Any other questions?
So
yes.
when you treat emergent hypokalemia, like with EKG changes or less than 2, is the rate of replacement any different? Because when we normally order IV through a peripheral line, it's like only 10 milliequivalents in 1 hour, kind of. So do we have to choose a different route?
Yeah, great question, Pritham. It depends. So why do we do this kind of slower rate? it's really because of the veins, because otherwise the patients will tell you it burns. And so if you have somebody who's that sick and you want to replace, you better put a central line, and then you can give it with a higher kind of rate of replacement. I would still, again, I would still be cautious of kind of being too fast, but if you need faster than the 10 milli equivalent, put a central line and you can replace faster. Excellent. Those are excellent questions, and you guys are an excellent engaged group toward the end of the day. So thank you. It makes it fun. Okay.
Dr. Mustafa, sorry, I had one last question.
Yes.
So it's about calcium gluconate. So this is more, I guess, a question for when we're on the floor and EKGs just take a while to come back. But I mean, what's the harm of just preemptively giving some calcium gluconate until we get the EKG back? I've heard like some different answers on this. So I was hoping if you could clarify.
So tell me, what are the answers that you've heard? Nisha, that's a great question.
Well, some people say like, why do it? And I always say, but what's the harm of giving it? I mean, if you're really scared about them going into arrhythmia from this, you should just go ahead and give it. And I don't feel like people can give me a proper answer why not to.
Nisha, great question. It all depends on my pretest probability. Some of my patients who I just hear the name, they're my frequent flyers who come to the ED all the time. I actually, before labs, I tell ED, okay, give them calcium gluconate. You know, I ask them to actually draw the lab. I think the one harm is if you give it before drawing the lab. Just draw the lab, make sure it's somewhere cooking, and you can give calcium gluconate as long as they're not hypercalcemic. You know, that's potentially, but there is really little harm in giving calcium gluconate, especially because you're really stabilizing the pericardium, and I think that's appropriate. But it is all about your pretest probability, you know.
Okay.
Yeah. The other thing is, again, any medication you give IV, you can have, again, it's very rare, but you can always have some sort of like a rare complication. So you don't want to give IV things unless you have to, but I think it's a safe practice if you have high pretest probability.
Gotcha. Thank you so much.
Sure. Okay, so now we're going to talk about the next case. I have a 42-year-old man brought to the ED by his sister due to hallucination and lethargy. You look at his labs, and the sodium is 97, and his potassium is 4, his plasma osmolality is 22, urine osmol is 82, and urine sodium is 25. Okay, I want all of you to tell me which of these 4 diagnoses do you think it is. You can use the chat.
Psychogenic.
Okay, what else? Anyone? Why did you say psychogenic polydipsia?
If you want to start. So for me, if you find that there is like serum sodium and urine sodium, both of them are on the lower side. So most probably it's like secondary to like psychogenic polydipsia, where you drink like plenty of like water orally and you keep diluting the serum and the urine sodium as well.
Okay. Any other thoughts?
If the urine sodium was greater than 40 or urine osmolarity was greater than 100, then that would be more SIADH picture, but the labs point away from SIADH more towards polydipsia.
Yeah, so great point, all of you, but this is not a straightforward case because you actually have a urine sodium less than 25, less than 40. But typically with polydipsia, we even see it lower. Sometimes we see like 10 and lower, but you're absolutely right. This is likely the most likely diagnosis. Okay, now how would you raise the plasma sodium concentration? So let's talk a little bit about, I have to tell you, I know hyperkalemia is the most fatal electrolyte imbalance. Hyponatremia is the one that keeps me up at night as a nephrologist, because you really want to correct this properly and you don't want to screw it up. So let's see. Okay. The osmolality is normal between 280 and 295. Osmotic equilibrium tightly regulated between extracellular and intracellular compartment. Water moves between the compartment in response to alteration in osmolality of either compartment. And this is how we calculate the osmolality. So you multiply your sodium by 2 plus BUN divided by 2.8 plus glucose divided by 18. So you see that the majority of your osmolality is really driven by your sodium. Okay. Serum osmolality is tightly regulated. Sodium is the major determinant. Sodium balance is regulated by the kidney, and serum sodium does not reflect total body sodium content. There is a category called factitious hyponatremia. It's when you draw from an indwelling catheter. So you guys talked about this already. I always, when I see hyponatremia, you want to make sure it wasn't drawn where the IV is actually hanging. Hyperlipidemia, usually there is normal plasma osmolality. Hyperglycemia drives the water into the extracellular space, so diluting the sodium concentration. Plasma osmolality will be high in this case, and sodium decrease 1.6 milliequivalent per liter for each 100 milligram per deciliter rise in glucose. So if you want to adjust, you can always calculate what you think is the true sodium is. Okay, there is acute or hyperacute versus chronic. Acute versus chronic is this 2 days, 48 hours time. Really the only time that you can diagnose acute hyponatremia very confidently if they are in the hospital and you have daily labs. Otherwise, it's very challenging. Mild, if the sodium is more than 130, moderate, the sodium is more than 120, and severe is below 120. I think if you want to remember one number, it's the 120. When you're sodium below 120, it's really tricky. There's, again, hyponatremia that can be because of loss of sodium, gain of water. Most common electrolytes abnormality in the hospital is hyponatremia. Most patients are stable, and if acute and severe, it can result in severe morbidity and death. So it's a serious. The sodium, the hyponatremia, because of loss of sodium, that you lose more salt relatively to the water. So you can still be hypovolemic. Hyponatremic dehydration, GI losses, hypotonic intake. So there is losses and patients or people are drinking hypotonic solution. Renal losses, chronic diuretic use, salt wasting, nephropathy, and adrenal insufficiency can all cause hyponatremia. And then skin losses, especially in patients with cystic fibrosis. How about hyponatremia due to gain of water, hypervolemia, fluid overload like congestive heart failure, or water intoxication like hypotonic fluid intake or hypotonia, which you guys identified in our patient. SIADH. And this is, again, just a description of different mechanisms, hypovolemic, hyponatremia, euvolemic, or hypervolemic. I think the key to remember is when your urinary sodium is quite low, very low, you have to think about hypovolemic hyponatremia due to extrarenal losses. So somebody has diarrhea, vomiting, pancreatitis, a fistula somewhere, and again, kind of manifesting with diarrhea, or if you have what the kidneys sense as hypovolemia, which would be something like congestive heart failure or liver failure, nephrotic syndrome, where the kidney is sensing that there is low volume. Then they hold on to the sodium, they keep it in. So the sodium in the urine will be low. Majority are asymptomatic. However, there is quite convincing literature that even with mild hyponatremia, like when the sodium is above 130, there is subclinical gait and mentation abnormality that you would not figure out unless you do extensive physical exam, which none of us do really. With mild to moderate symptoms, it can be headache, nausea, vomiting, fatigue, gait disturbances, and confusion. With severe symptoms, it can be as bad as seizure, obtundation, coma, and respiratory arrest. Who to treat emergently? Patients with severe symptoms due to hyponatremia, such as seizure or obtundation. Patients with acute hyponatremia, so remember, acute is within 48 hours, who have symptoms due to hyponatremia, even if such symptoms are mild. So if you have acute hyponatremia, even if mild symptoms, just treat emergently. Can result in life-threatening cerebral edema if you don't. Patients with hyperacute hyponatremia due to self-induced water intoxication, even if there are no symptoms at the time of initial evaluation, be very careful if the patients have these hyperacute hyponatremia. Brain herniation has been reported in such patients, and the serum sodium may worsen spontaneously due to delayed absorption or ingestion water. I actually seen the worst case I've seen of this, I want to say 3 years ago now, is a lady who had a specific religious fasting, and the fasting was for 10 days except for water. So she was only allowed to drink water, and she was drinking so much water. She came in with a sodium of, I believe, 81, and had came in because of, her husband noticed that she's not acting well, but because she was already continuing to drink water, that sodium continued to drop, and she had actually brain herniation and passed away. So symptomatic patients who have either acute postoperative hyponatremia or hyponatremia associated with intracranial pathology, you have to treat. Goals of therapy. The goal of emergency therapy is to rapidly increase the serum sodium by 4 to 6 milliequivalent per liter over several hours. That's again, these are the people who you want to treat acutely. Okay, but the increase in serum sodium should not exceed 6, and I put 8 in question mark. We used to say 8 to 10 a few years ago, and now we say 6 to 8. Really, I like to keep it close to the 6 milliequivalent in any given 24-hour period. And that is really challenging, because if you don't do that, if you rapidly correct hyponatremia, it can lead to osmotic demyelination or central pontine myelinosis, brain herniation, seizure severity, and of symptoms. So hypertonic, the way you treat is you can give hypertonic saline, usually as 100 ml bolus, given over 10 to 15 minutes, followed by slow continuous infusion. You need to follow the BMP and serum and urine osmolarity every 2 hours initially. You can give desmopressin, 1 to 2 microgram IV or sub-Q every 8 hours for 24 to 48 hours. Desmopressin will make the rate of correction resulting from hypertonic saline more predictable, because it prevents an unexpected water diuresis from occurring during the course of the therapy. Okay. Do not use desmopressin in patients who are at high risk of self-induced water intoxication. Essentially, desmopressin, okay, is kind of controlling what happens with the urine. So if they're gonna take water, then they will drop their sodium, and you can't manage it. I want to just take a minute and talk about this. I haven't worked in any place where the labs come fast enough with these 2 hours. So typically you get the labs every 2 hours, but you're at best looking at the labs 45 minutes after they've been drawn, at best. So you always have to be proactive when you're managing a hyponatremia, because if they're already correcting too fast, on the lab I got 2 hours ago, like in the last lab, I really should do something because they're already lower now compared to what I see. So you really have to be proactive and on top of your labs with this. We do not typically use hypertonic saline in patients with chronic moderate hyponatremia who have mild to moderate symptoms, or in asymptomatic patients with severe hyponatremia. Such patients are typically treated. You start with fluid restriction. Of course, it depends on the cause, but many of them will respond to fluid restriction with or without loop diuretics and oral sodium chloride, or now available in many places, urea sodium. But again, if they're hypovolemic, like they're dehydrated, sometimes you want to give them some fluid. But again, be careful with overcorrection pretty fast. If you insufficiently correct, hyponatremia can lead to cerebral edema. If you're too aggressive in correction, it can also lead to demyelination. So you really want to treat acute hyponatremia is the most dangerous. That's why you want to treat it very quickly. Symptomatic hyponatremia is a medical emergency. Again, correct the underlying cause, hyponatremic dehydration or SIDH. You want to give do fluid restriction for SIDH. When you do fluid restriction, please always calculate the insensible water losses. So this, automatic 2 liters or 1.5 liter or 1 liter fluid restriction doesn't work. You really have to have an idea of what is their baseline fluid intake and kind of go below that. You also want to know about how much urine they make in 24 hours. Rate of correction depends on how quickly it developed. Acute hyponatremia is more dangerous. Increase the risk of herniation and apnea from increased intracranial pressure from rapid and unbalanced water movement into the brain cells. In general, correction with hypertonic saline is unnecessary unless there is neurological manifestation of hyponatremia. Let's talk about this case and then we'll take a small break for your questions. So case 4, 62-year-old woman intubated in the ICU, and guess what? The sodium is 155. So now we're going to talk about hypernatremia. It's when the sodium is more than 150, always abnormal, and should be evaluated. Okay, it is almost always, it's a free water deficit issue when you have hypernatremia, or that there is increased sodium intake or retention, which is really not the most common one. Increased serum osmolarity and does not imply total body sodium overload. Rarely develops in those who have access to free water. If they can drink, the thirst mechanism will correct hypernatremia. It's people who don't have access to water who you see this with. Most often from inability to access water. At risk is the critically ill, intubated, neurologically impaired. Again, water deficit, there can be renal losses, so diuretic use, nephropathy with renal concentrating deficit, or diabetes insipidus, or extrarenal losses, vomiting, diarrhea, or skin losses. Hypernatremia due to increased sodium intake or retention, salt poisoning, rare, can happen. Exogenous sodium, so hypertonic feeding, hypertonic saline, or we're giving them a hypertonic feed. This is very common. Sodium bicarb administration. We see this a lot after codes. You're giving them a pretty high sodium load when you give sodium bicarb. So just keep that in mind. Mineral corticoid excess and hyperaldosteronism. How do you evaluate the patient? You determine their volume status. That's the first thing. You want to check their blood pressure because you want to see if they're hypo or hypertensive. Renal water loss, you can look at kidney does not appropriately respond to hypovolemia, low urine, specific gravity and osmolality, and the high urine sodium. And then extrarenal water loss, its kidney responds appropriately to hypovolemia. There will be high urine specific gravity and low urine sodium. How do you treat? You treat the cause, correct the volume disturbances if present, and calculate the free water deficit. the way to calculate it's 4 ml per kg times the desired change in your sodium. So again, if somebody has, and I've seen patient was like 179 the other day, I'm not going to correct them to 140 over 24 hours. So I'm going to do this gradually. There is always a risk of cerebral edema from rapid correction, so be careful. Let me stop here and see if you guys have any questions.
I have one question.
Go for it.
So you, for example, suppose you're treating hyponatremia and it's severe, less than 120. You're treating it with hypertonic saline, and for some reason you just miss one lab and you overcorrect.
Mm-hmm.
So this happened once with me. So our goal was 124,
mm-hmm.
and it went up to 127. I went and saw the patient. The patient did not show any symptoms, no change in mental status, absolutely fine. What do? Do you go back to 124? Or
I do.
You there and pray God?
No, the prayers don't always work in these situations. I've tried. You can always pray, but I would actually, depending on what I do, I will either, most likely in this case, I will stop the hypertonic, because at 124 anyway, you're probably out of that danger zone if they have no neurological symptoms. But I would give them some free water. And try to bring it down a little. And I've done that. So that's totally appropriate. It happens even, as I said, this 2 hours. If I can find a way to know what their sodium now is, not what happened when I checked the blood. So it happened often that they're more rapidly correcting. I know that at 5 p.m. I want them to be at 129. And it's 5 a.m. today, and we're already at 127. I know we're fastly correcting. So I usually change the rate and give them D5 water if needed or something. Excellent.
Another question.
Uh-huh.
Like at night, what's the thing that, like for hyponatremia or hyponatremia, that you would like us to wake you up in the middle of night?
Well, speaking on behalf of myself, not the whole nephrology group, they're gonna not like me. I honestly think if you are about to give somebody hypertonic, I think a nephrologist should be on board. That's fair. If you think they're sick enough that they need hypertonic saline, I think it's fair. If you're rapidly correcting and you don't know what to do, you stopped your hypertonic, or you didn't give hypertonic, you're giving D5 and you're still rapidly correcting. A lot of the time what I do in these cases, I give them desmopressin, because I want to take urine out of my equation. I want to manage everything by the fluid I'm giving until I kind of get them to where I want. So I think if you're about to give desmopressin to manage, it's also fair to get nephrology on board.
You just have one comment.
So is it like routine to get desmopressin or not? So is it like for everyone?
No, it's not for everyone, but we use it. It's not a rare occasion that we give desmopressin. It's really if it's usually when the correction is not going according what I'm expecting, when I'm just using fluid, I would intervene with desmopressin. Again, rapid correction is one of those cases where I would intervene.
Thank you. Just one quick comment regarding what Dr. Mustafa said for the delay of labs. I just wanted to be sure everybody knows that the ABG machine can give you electrolytes in few minutes. So if you really need immediate thing, order the electrolytes in the ABG machine and page RT immediately, give him the sample. He will get back with you with the electrolytes within 5 minutes or so. And we are nearly close to get some machine that can give you the results immediately in the ICU.
That's great. So these point of care machines, that's great. And I'm sure Ashraf and your team, you will know how accurate these points of care are. We use the point of care for potassium quite a bit, not yet for sodium, but that's a great point. Thank you. Okay. I'm gonna go and continue. But again, you know, you can stop me at any time. Okay, the fifth case. Have a 19-year-old female with headache, constipation for 6 weeks with abdominal pain. She's on hydrochlorothiazide for hypertension. Okay, her blood pressure is 160/92, quite high. Out of her labs, what stands out, just to save time, is the calcium of 13.8, and she has an elevated lipase. So hypercalcemia. Stones, bones, moans, groans, and EKG changes. This is, I copied from UpToDate, and I really like this. And that's how I think about many of the patients I see with hypercalcemia. I start by thinking, you know, you want to confirm it, you evaluate them clinically, and you're going to get a PTH. If they have an elevated, you know, or mildly high PTH, that's abnormal, because with hypercalcemia, the PTH should be suppressed. If it's not, then you want to think about primary hyperparathyroidism and consider familial hypocalciuric hypercalcemia. So, and then you determine or you distinguish between those two based on the urine calcium, okay? If your PTH is low, which is what you expect in hypercalcemia, so it's not a PTH-driven mechanism, and in that case, you start thinking about, you know, PTH-related protein, vitamin D, you think about 125 and 25, so you start thinking about other causes of, but really, the main thing you want to think about, again, clinical evaluation is the first. So medication is a very often contributor, especially now. A lot of people love to take vitamin D and calcium over the counter. It is unlikely that just because they're taking high supplements that you will see a potassium of 13 though. Okay, treatment. Most hypercalcemic patients are also volume depleted. Okay, hydration to increase urine output and calcium excretion. So you want to start with hydration. Give them normal saline because you want the salt. This is one of the situations where if they're making urine and you're giving them high amount of normal saline, you can prophylactically start replacing potassium because they're going to excrete potassium with the urine. Maintain a renal function and blood pressure allows. So only if they're making urine and their renal function and blood pressure will allow you to do though. Forced diuresis. So I would not diurese somebody who's hypercalcemic unless I've totally, you know, I know that they're fully hydrated. At that point I would, and maybe I start seeing some edema. So, but if you're gonna diurese them, definitely loop diuretic, nothing else. You don't want to do hydrochlorothiazide. Calcitonin, bisphosphonate, and I've had to dialyze patients because of really, really severe hypercalcemia. Hypocalcemia, I think the one thing, again, maybe not an ICU emergency, but a lot of the time these patients get missed. You know, you treat the hypercalcemia, but nobody asks themselves, why are they hypercalcemic? A lot of the time there is malignancy or something driving that. And in this case, in the patient we looked at, remember that they also had pancreatitis. So that hypercalcemia precipitated the pancreatitis. Okay, and with the pancreatitis, now they became further dehydrated and intravascularly depleted. Hypocalcemia. There is an increased phosphate level. If they have increased phosphate level, that's usually chronic kidney disease or that they're taking some sort of phosphate therapy. It can happen with hypoparathyroidism. Post-thyroidectomy hypocalcemia is the most common I actually deal with in the hospital. Congenital deficiency, severe hypomagnesemia can actually also precipitate hypocalcemia. Vitamin D deficiency, resistance to the parathyroid hormone, drugs if they're on calcitonin or bisphosphonate, and others like acute pancreatitis sometimes can precipitate hypocalcemia. Citrate blood in massive transfusion. Remember that when you have somebody who's bleeding in the ICU and you're just giving massive transfusion, low plasma albumin, malnutrition or chronic liver disease, and malabsorption or celiac disease. Clinical manifestations: paresthesia, muscle cramps, carpopedal spasm, tetany, seizure, laryngospasm and stridor happens more with kids, cardiac arrhythmias, and these are specific Treforstics and Trousseau's signs, how you can predict it, especially if it's subclinical. Depending on the underlying cause and severity, you can administer calcium alone if only, and it will only transiently be effective. However, for mild asymptomatic cases, you can replace orally. If they are symptomatic, you want to treat immediately, replace with IV calcium, and you want to put them on cardiac monitoring. This is the one I see people sometimes forget. If the cause is because of hypoparathyroidism, okay, you want to aim to keep their sodium, their serum calcium between 8 and 8.5, oral calcium supplement. You want to give them active preparation of vitamin D, so calcitriol or alpha calcitriol, and you really want to monitor not only the plasma calcium, but you want to monitor their calcium to creatinine ratio in the urine. Hyperphosphatemia. This happens very often to us, again, when, especially when there are new nurses in the ICU for patients on CRRT or something. Somehow hyperphosphatemia is not an emergency. That you can treat it, you can take care of it, but it is not something to lose sleep. And don't call a nephrologist for it, please. Hypophosphatemia, on the other hand, it can be an emergency. So it can happen from renal losses, insufficient gastrointestinal absorption, or transcellular shifts. So respiratory alkalosis can precipitate it, heat stroke, aspirin poisoning, and so on. If you have hypophosphatemia, if the phosphate is below 1, you want to actually treat with IV phosphate, but you always want to know why. There is also medication. Tenofovir is a common one known to cause hypophosphatemia. So if the patient's having diarrhea, you want to address that, but you can treat with IV only if it's really, really low. And the concern with hypophosphatemia is that it can affect the breathing muscle, the diaphragm, and they can stop breathing. One thing to keep in mind is a lot of the preparation for phosphate has also potassium in it. So it can be very challenging to replace phosphorus if somebody has high potassium. And you can give them sodium phosphate. However, that comes as IV mostly. I'm going to give you a trick. You have a patient who has low phosphate and they have potassium, and you really want to try to correct their phosphate. What can you tell them to drink that has phosphate, doesn't have potassium in it?
Dairy product.
Dairy product has both. Good answer, but you will increase their potassium too. I actually had a patient who I told them to do this last week and they thought I'm crazy. Coke. So the actual dye in the Coke is, it has a lot of phosphate in it. So Diet Coke will give them phosphate and not give them potassium. And the patient said, "Doctor, you're the first doctor ever to tell me to drink Coke." And I said, probably the last also. So just keep that in mind. It's really but that's why with patients who are on end-stage kidney disease, we tell them not to drink Coke. And I tell them if they want to drink, carbonated beverages, let's just make sure that it's 7-Up or something that doesn't have the dye because of phosphate. Okay. We're getting close to the end. I'm going to go faster, just over very few things. So hypermagnesemia, 28-year-old with end-stage kidney disease on chronic peritoneal dialysis, has a serum magnesium of 3.2. He is asymptomatic. All other values are normal except the PUN and creatinine. A lot of the time, hypermagnesemia happens in renal failure and excessive administration. Sometimes people are on supplement and they're taking a lot of magnesium. Symptoms, it can manifest as decreased deep tendon reflexes or lethargy or confusion. Hypocalcemia, hypermagnesemia suppress PTH. That's why it can cause hypocalcemia. Rarely of clinical significance, really. And it is really not an emergency most of the time. Just stop the supplement of magnesium, diurese them, or dialysis. I want you to not forget two things, okay? Consider hypomagnesemia in cases of refractory hyperkalemia and hypocalcemia. If you're trying to treat that potassium or calcium and it's not getting up, check a magnesium level. The other thing I want you to always remember, always treat hypokalemia and hypocalcemia first if they also have acidemia. So don't start by replacing their bicarb because that will drive their potassium even lower and you don't want to do that. So make sure you replace the potassium or calcium first before you treat their acidemia. And I will end here and I am happy to answer any questions if you have any left.
Dr. Mustafa, in patients with hyperkalemia, when do you decide to give both IV fluids and Lasix at the same time?
Yeah, caluruses. If they're making very, very good urine, okay, and I really want to get rid of the potassium, so they come with hyperkalemia, they're making excellent urine, they're not fluid overloaded. If they're fluid overloaded, I would just give a diuretics. So they look euvolemic, but they're having this hyperkalemia, I would do it. Again, rarely, because you kind of have to make up your mind. But in these situations, normal saline with diuretics will get rid of the potassium. Excellent question.
What is the utility of ionized calcium in hypocalcemia in an ICU setting, let's say?
Well, if you have, if you have somebody with an abnormal albumin and you're always trying to correct to actually calculate the true level, it is quite reasonable to check an ionized calcium to make sure that your correction is actually appropriate. So if they're hypocalcemic, and I would check an ionized calcium, I think that's quite reasonable.
I think also in patients who received the massive blood transfusion.
Excellent point. Yes. So with those patients, because of all the citrate, that can drive hypocalcemia. Mm-hmm.
Because there was so in the ICU, I had a couple of patients with hypocalcemia, and I was reading online what to do in the night, and they were like, check an ionized calcium. And I checked it and I didn't know what to do with it. I just gave the same thing.
Well, I think that the reason they want you to check an ionized calcium is to confirm that it's true hypocalcemia, because sometimes the calcium is protein bound. So if you have low albumin, the calcium may be low in the serum, but when you correct it for albumin, it's actually not, the patient is not hypocalcemic. So before you start and you want to kind of go ahead and do a lot of replacement, just confirm. That's why you get the ionized calcium, is to confirm that it's truly low. However, if somebody, for example, is symptomatic, I had the patient who had parathyroidectomy, and he told me I stopped taking my medication. He came with all kinds of, paresthesias, and I didn't wait to confirm anything. I started the replacement and then was checking ionized to make sure that we're correcting.
One question.
Ionized calcium is in the ABG machine, so you can get that quickly. And also ionization of the calcium depends on the pH.
So Ashraf, just to make this practical, when you say depends on the pH. So if you have somebody who's quite acidotic, you have to keep that in mind when you're looking at ionized calcium.
Yeah, that will increase the ionized calcium. So acidosis will increase ionized calcium. Alkalemia will reduce the ionization of the calcium.
Very good. Thank you. Somebody had a question.
Oh, yeah. If you are treating one with severe hypercalcemia, like 14 something, the calcium, then you are doing the IV fluids, and at what point you will stop the fluids based on the calcium level or the volume status or kind of both?
Yeah, excellent question. So as I said, almost always when they have such high calcium, they're intravascularly depleted at the same time. So they need IV fluids. I will continue the IV fluids. It depends on what's causing it and what's my long-term plan for them. Okay, if this patient have some sort of a cancer, I want to get them to a safe place. I might give them bisphosphonate or, depending on the level. And I want to make sure I continue this management until the calcium is reasonable. I will, if I had to, give Lasix with the fluid. I will keep it going until I make sure that the calcium is in a safe zone, which is definitely, I want them to be below 11 or so before I would stop. So, and only if I feel they're become hypervolemic, I give them Lasix. Otherwise, I just treat with fluid. Anything else?
Looks like no. Thank you very much, Dr. Mustafa. We appreciate the lecture, wonderful lecture. And thank you everybody for attending the course today. Tomorrow we'll meet at noon. We'll start exactly at noon, so please be in time. And have a good night.
Thank you very much. And thanks, Ashraf, for organizing this.
Thank you very much.
You guys take care. Bye-bye.
Thank you both.
Thank you.
You're welcome. Thank you.